Good day. I'm John Edwards. I'm a professor of pathology at Texas A&M University, and today I'm going to talk to you concerning the macroscopic or gross anatomy and lesions of the horse. At the beginning of my talk, I'd like to acknowledge my colleagues who've helped me not only in terms of contributing material for this lecture, but who've helped me through the years in discussions and debates, so to speak, regarding the different changes we see in the horse. And the lecture will contain a lot of material that will have lesions similar to other species. It's just that you're going to see it in the horse, and I suppose a ventricular septal defect in a horse is very similar to a ventricular septal defect in a cat or a dog. There are a number of lesions that we'll cover that are specific to the horse, and I'll point those out as we go through. They're slides that are taken from spontaneous diseases collected over a large number of years, and I hope you enjoy it. Let's go to the first slide. During this lecture, instead of a lighted pointer, I think for visibility's sake I'm going to use a pointer that's just an old-fashioned rod, in that I think that through the video you'll be able to better see the pointer if I use it that way instead of a lighted pointer. First slide, please. We'll begin by talking about the central nervous system, and a very typical lesion in the horse is the horse that's got hirsutism. Hirsutism is a gross lesion seen in the horse with a chromophobe adenoma of the pituitary. And here in this photograph you can see on a hot day in the subtropical climate an animal with a very, very thick coat. That is very, very diagnostic of the situation when you've got a chromophobe adenoma. Here we have in the bottom of this slide, you see the adenoma at the bottom of the brain compressing the brain stem to a certain degree. Most of these horses are presented without clinical signs referable to CNS dysfunction. Rather, they are presented with lesions related to polyuria, polydipsia. In some cases, they'll have weakness, muscle weakness, things suggesting in excess amounts of cortisol, and at times they'll have hyperglycemia that's non-responsive to insulin therapy. If you look at the base of the brain inside the skull itself, the pituitary gland is dome-shaped in these animals as opposed to being very, very flush with the bottom of the brain. And sometimes the swelling is symmetrical, sometimes it's asymmetrical, and it can be of variable size. When they do get large, they can be very hemorrhagic and, of course, cause compression on the ventral part of the brain. This was an animal that actually was presented for signs referable to CNS dysfunction. Another common lesion in the horse, this is again a specific thing to the horse, are accumulation of cholesterol in the choroid plexus, called variably cholesteatomas or cholesterol granulomas. They are very, very non-inflammatory in nature histologically and represented best as depositions of cholesterol salts inside the choroid plexus. It's not only seen here as you're seeing it in the ventricular choroid plexus, but also underneath the lateral hemispheres of the cerebellum you'll find these same cholesterol structures. They'll be very pale in the unfixed specimen and are very, very common in the horse in the choroid plexus. Here you're looking at the brain and you're seeing that there are very, very prominent gyri, in that they're deep sulci and the gyri are very, very thin, so they look very, very prominent. You'll also see that the hemispheres have pulled apart to a certain degree and that the cerebellum is much more visible than would normally be observed in a horse when viewed from the dorsal position in the brain. And here you're looking at cerebral atrophy. This is due to senile atrophy, the degeneration of certain neurons and lipofunctionosis of neurons with their loss, and a lesion seen in a horse with old age to my knowledge, lipofuscinosis with juvenile cerebral atrophy has not been described in the horse. You're looking at a young horse, and again you can see the cerebellum very, very well, and that's because you have a collapse of the cerebrum. And in this case you're seeing hydrocephalus and hydranencephaly. Large areas of the cortex here are not visible as typical gyri and sulci, and also you see it down here. Better seen perhaps in cross-section, where you've got a dilated ventricle, the hydrocephalus. We have areas where the neuropile is not as you're seeing right here, where there's some remnant neuropile. Rather, it remains as just a membrane here, and over here you can see it where the pressures have led to loss of the neuropile. This particular colt, by chance, was also positive for Cache Valley virus. Cache Valley virus is very, very commonly seen in horses, although malformations due to Cache Valley virus are not common. Congenital hypoplasia of the cerebrum. Again, you're seeing a very, very prominent cerebellum. The geniculate bodies are visible, and very, very small cortices in this animal. We're talking about a situation that is really unexplained. It doesn't happen all that frequently. But again, to remember that you can see any malformation that you could see in any of our species in the horse, and there are any number of 1 or 2 times in my lifetime type of lesions that you'll see in the horse, and you all have your own collection probably. You'll also notice that it's typical of hypoplastic brains that you have a very thickened skull bone as well. You're looking at a segmental lesion in the spinal cord of a horse after fixation. This is the cranial thoracic area. This is the caudal thoracic area. And in the center we have 3 sections of a lesion of hydromyelia or syringomyelia. In this case you can't tell grossly whether this is a segmental dysraphism, whether it's a failure in closure, or whether or not there was a focal area of necrosis with expansion of the neuropile that became continuous with the central canal. But a nice lesion of hydromyelia and syringomyelia in a segmental nature in the thoracic spinal cord of a horse. When viewed laterally, it looks as though the animal has a very, very small cerebellum here. In this animal, it's about 7 months old. It's an Arabian horse, and you're looking at a case of cerebellar abiotrophy. These animals are, as in other species, born normally, and then they have a progressive increase in ataxia, signs referable to loss of cerebellar function, cerebellar abiotrophy. This is not hypoplasia. The cerebellum was normal in size or near normal in size in the younger animal, and it became progressively degenerate till you have a small cerebellum. When you're dealing with meningitis in horses, in the early stages the lesions can be a little bit more subtle, but you're looking at cloudy spaces between the gyri. The sulci have turbid meninges, and that's due to an accumulation of exudate inside the meninges. The meninges look injected. They're also, in some areas you can actually see an accumulation of enough exudate so that you can't see through it, as opposed to over here where the meninges are just turbid. It's early suppurative meningitis in a foal. These can become very, very severe if the animal is maintained for a long enough period of time alive before it dies, and you can see that the exudate can be so bad that it will actually totally obfuscate your view of the cerebral cortex. Suppurative inflammation in the horse's brain can also periodically be seen as an abscess, and you're seeing in the lateral hemisphere of this brain an abscess in the horse, a Streptococcus induced abscess. We see these in juvenile horses. You can see them in any age animal. However, we see them most often in juvenile horses, and I suppose in reality we see them most commonly associated with valvular infection, valvular endocarditis. Looking again in the floor of the skull, in the cranial vault, and we're seeing a discolored area of tissue surrounding the pituitary. I remind you to remember what the pituitary looked like in the animal that had the adenoma. This one, of course, is lying much more flush with the floor of the skull, and you've got that greenish brown discoloration around the pituitary, as well as perhaps a little bit of extra hemorrhage. It doesn't just run away when you rinse out the skull for the photograph. So this is a pituitary pituitary infection, a peripituitary abscess. These things are seen in horses, often associated with guttural pouch infections and tooth infections. And in one particular case, we were able to photograph the guttural pouch membrane is over here, and medial to the guttural pouch we had a fistula, a suppurative fistulous tract that also was associated with a pituitary abscess. And it's believed that the infection travels up to the pituitary from infections in this area of the brain, of the skull. Septicemias sometimes will give you focal areas of encephalitis, and you're seeing multiple areas in this side of the cortex of an embolic phenomenon in a septic fold, and again, multifocal hemorrhagic and necrohemorrhagic encephalitis in a horse, bacterial in nature. In horses that have colonic disease, if you don't just look at the GI tract, which is an obvious lesion, and look at the brain, you'll often find areas of hemorrhagic necrosis, encephalitis as well, here, and down in here, as we have embolic phenomenon going to the brain in horses, most commonly in my experience with salmonellosis of the colon. These animals will have an embolic shower to the skull. These animals being so moribund that often the CNS component is masked by the just severe deterioration of the physical condition of the horse. But here we have, again, salmonella-induced and embolic encephalitis from an animal with severe colitis. There are a number of viral entities of the horse that lead to histologic encephalitis, and of course they all aren't associated with gross photographs that I can show you lesions. Encephalitis due to a number of bunya viruses have been described. You don't see gross lesions with those, nor do you see it very often with the encephalitis from equine infectious anemia. You're looking at the cross-section of the spinal cord of a horse with rabies. Rabies will occasionally have hemorrhagic lesions inside the central nervous system that can be seen grossly. This is seen most commonly in the horse with rabies in the spinal column, and that's what you're looking at. This animal had no histologic lesions, very few Negri bodies as well in the brain, but in the spinal cord there were these beautiful lesions in the thoracic and cranial, cranial thoracic and caudal cervical spinal column. Here we're looking at some sections of a horse that had an acute onset of ataxia, and you're seeing hemorrhages, and they're often linear. As you look at these hemorrhages, you can see that they seem to be linear, suggesting that they're following a certain structure. And this is myelitis, hemorrhagic and necrotizing myelitis in an animal with equine herpes virus 1 infection. And it's got a vasculitis histologically, and you can see that in these linear hemorrhages very nicely. Protozoal myelitis, whether it's Sarcastic Neuroni or whether it's Neospora, can be seen grossly. You'll see it in the spinal cord. Here you have a bilateral, almost symmetric areas of hemorrhage and malacia on cross-section of this spinal cord. Or you can also see it in the brain stem and in the cerebellar nuclei of this section. Most obvious down here in this area of the brain stem, a little bit more lateral as well, but up in here there's also histologically very nice lesions related to protozoal myelitis. This was Sarcastic Neuroni. With the advent of many of the deworming agents that are treating our nematodes very successfully, we don't see this very often. Here you're seeing an infarct in the brain due to strangile migration. You're seeing an area of locally extensive depression and loss of neuropile. There's some hemorrhage and old hemosiderin in that lesion, and this is an animal that had an infarct in the brain from strangile migration. not seen very often because of now, as I speak, because of the efficacious deworming agents. You're looking at the cross-section of an 8-day-old foal, and you're seeing the areas of poliomalacia running up in these dorsal gyri. This was a Barker foal, a dummy foal, an animal that was kept alive for 7 days on oxygen and rather heroic supportive therapy. The animal had been in a dystocia, underwent a severe period of anoxia, and laminar cortical necrosis is very commonly seen with severe anoxia. Horses don't get clinically the thiaminase problems that you see in feedlot steers, for example. However, this is typical of what you see in a dummy foal that's undergone anoxia and has subsequently been kept alive for a long enough period of time, just seeing the necrosis of the gyri. These animals will have unusual vocalizations and are sometimes said to bark like a dog. Again, bilateral, symmetric malacia and necrosis of the brain stem. This is a nigropallidial encephalomalacia that's typical of the Russian yellow star thistle intoxication, a problem we see in the northwestern part of our country. Nice lesions, bilateral and symmetric down here in the basal nuclei of this brain. In periods of time when they're feeding corn with fumonsin, we see encephalomalacia in the brain of horses, and you're seeing here not, again, a bilateral lesion, but not symmetric in that this is a much more severe lesion on this side and a milder lesion over here in this horse with moldy corn intoxication. This is a degenerative lesion, a malasic lesion, a necrotic lesion, a lesion beginning as a vascular lesion and secondary neuropile degeneration around the affected vessels, moldy corn poisoning, leukoencephalomalacia. In any case of malacia in the brain, if you look at the brain and cross-section under an UV lamp, you can see the areas of fluorescence that indicate areas of malacia. And this isn't any species, and it just shows a change in the neuropile that does cause quenching in certain areas and fluorescence in others, so it's a nice test to use in a diagnostic situation. Not all CNS lesions are seen in the gross lab, of course, in the dead animal, and many are only seen histologically. This is a horse that shows us very nicely, a horse with sorghum cystitis. Not only does it have the cystitis, but the cystitis comes from a neurogenic problem in that it can't empty its bladder very, very well. There's no good urine flow, and these animals will stand with a typical sawhorse stance. They will, this is a gelding, and it's got a lot of urine scalding on the inside of the limbs here because he's always dribbling urine. Sorghum, this is a sorghum, a breed of sorghum plant that they use as ground cover in certain areas of our country, and it causes a neurodegeneration of the spinal column. The urinary tract, of course, is dribbling urine because it loses its control of the sphincters and doesn't have a good urine flow, so that you'll have a cystitis. But on top of that, of course, you've got the histologic lesions of the degeneration. It's a degenerative lesion of the spinal cord. And again, you're looking at the urine scalds on the limb. And of course, it's not urinating, it's just running urine continually. Locoweed intoxication, again, you see here those signs of an animal that's ataxic. He's knuckling over and walking on he's walking on both of his fetlocks here in the rear. These animals, once an animal starts to eat locoweed, astragalus, they'll go out and they'll look for more plants of it. They'll actually get a craving for it, and they'll eat more and more of it, and they'll get a nice degeneration of the neurons, the cerebellum, accumulation of alpha mannose, and it's a model, of course, of metabolic neuron disease in some species, typically in the rat, but spontaneously we see it in horses where you've got locoweed. It's hard to tell what you're looking at here, but you're looking at the caudal end of the spinal column in a horse. Here's the cauda equina area of the spinal column, and you can't tell that that's normal dura or roots of nerves. They're all tied together by a fibrous and inflammatory chain, granulomatous polyradicular neuritis. And the neat thing, I think, of this lesion is when you do open up the spinal cord dura, you can see that this severe inflammatory change stops at the dura. Inside the dura, the roots don't look that terribly bad. Histologically, there'll be some inflammation in the roots right here, but the spinal cord itself is extremely normal looking, and you're looking at the inside of the dura and the very, very thick coat of granulomatous inflammation around it. A rather impressive lesion, typical of the condition in the horse. And again, the severe gross lesion respects the dura very, very nicely. You can see neoplasms of the spinal cord and brain in horses, but most neoplasms that you'll see are metastatic neoplasms. And in my experience, the most common metastatic neoplasm of the spinal column would be the melanoma. Here's one that's not as pigmented as you'd like, but is a melanoma. We also see melanomas extradurally, causing compressive lesions inside the spinal column. And we also see lymphosarcoma periodically. Here you're seeing it around the filoterminale area of the sacrum and coccygeal vertebra in this particular animal. I don't see very, very many primary neoplasms. Most are, as I said, metastatic, either melanomas, lymphosarcoma being the most common. Occasionally, I see a renal adenocarcinoma to the brain. Talk about the eyes for a moment. We have here a nice anterior uveitis in a newborn foal. As with our ruminants in newborns, we often see anterior uveitis when they have a systemic bacterial infection. And here you're looking at accumulation of fibrin and neutrophils in the anterior chamber of this newborn. When they do get polyarthritis and septicemias, this is often seen, just like in small ruminants. They don't get as many umbilical infections as ruminants, but when they get them, they will also have this very typical lesion, just like you see in calves. Animals that have trauma, or either self-induced or for whatever reason, can have hyphema. This could be seen in any particular species, but a good example of hyphema in a horse. And a typical horse lesion, you're looking at a chronic keratitis, iridocyclitis with pannus formation and anterior uveitis prominently seen here. In periodic ophthalmia, moon blindness, or chronic hypersensitivity to leptospirosis in the horse, periodic ophthalmia. In trypanosomiasis, you'll see a nice lesion on the cornea. It'll be clouded around the lesion. The sclera is injected. The animal is slightly icteric. A rather interesting lesion, often missed because people are more often impressed by the fact that they're severely icteric, and the lesions indicating some increased stimulus for of the erythron, and you have a lot of increased medullary erythropoiesis. This is a case of trypanosomiasis. You will, as you can see in any other animal, see with time any number of lesions that you'd see with congenital defects of the eye. Here we have a dermoid growing on the surface of the eye. This is not a squamous cell carcinoma. This is a dermoid, and it's got some secondary changes occurring with a keratitis from exposure, as well as inflammation of the cornea and clouding of the cornea secondary to having the dermoid in this young animal. I'd like to start talking about the endocrine system. There are a few very typical lesions in horses. Elderly horses commonly are seen to have focal adenomas, follicular or solid thyroid adenomas. They can become quite large, and in the throat latch region of this old stallion, there's a very, very large swelling that's associated with the thyroid. When you dissect it out, you can see that you have a tremendous asymmetric enlargement of the left thyroid in this animal, and on cross-section you're seeing macroscopically a lesion that shows what you look for histologically for a malignant thyroid neoplasm. It's invading beyond a capsule that it has formed of its own here, and the tumor is moving out into the parenchyma. It also has, you can't see it in this photograph, it started to invade vessels. Vessel invasion, very, very common, running down towards the thorax if you do a dissection of the throat area. Goiter is seen with some frequency. You have to be very, very careful when you look at young animals. This is a newborn horse, but it's got very, very large thyroids, asymmetrically enlarged as well. And goiter is seen with some frequency. Presumably in our area, we see it because of diets that are heavy in iodine. We have to be a little careful when we look at the thyroids from foals because they always tend to be a little bit enlarged. When you've got goiter, they're enlarged and often asymmetric and nodular in appearance. And on cut section, you can see macroscopically in this one, those structures that look like little bubbles are actually enlarged follicles. And this is a follicular goiter, hyperplastic goiter, and in a foal. If you look at the thyroid in animals that have endotoxemia, it's not uncommon to look and find an area of infarction. This is infarction on one side of the gland, and on the opposite gland, you see a normal thyroid parenchyma. These lesions are again seen in endotoxemias, and these areas of dry necrosis are very typical of an infarct. The parathyroid gland in this horse is very, very large relative to the size of the thyroid, of course. And this is an example of nutritional hyperparathyroidism, the most common cause of hyperparathyroidism in the horse in my experience. In this case, we're dealing with an animal who has been giving a diet of substances like bran that has a high amount of phosphorus, perhaps a low calcium diet, so that you have hyperparathyroidism to release calcium from the bones. When you're looking for parathyroid lesions in a horse, you've got to be a little bit careful because of all the species. This one has the parathyroid that may be located, just like in all of our species, near the thyroid, or it may be in the midline near in the ventral neck region just before the thoracic inlet, or it may, the parathyroids may actually be inside of the thymus. One never knows unless you have a problem specific with parathyroids where the parathyroids are for sure. This animal, of course, I found nice enlarged parathyroids where they're supposed to be, but there may have been enlarged parathyroids, excuse me, again in the neck area or in the mediastinum. I just didn't see them. But when they are in this area, of course, they're easy to find, and you can see the parathyroid lesion. I was fortunate in this case that this animal's parathyroid was associated with the thyroid itself. Parathyroid Kirsteiner cysts, relatively common. If you do look at parathyroids, most people don't see the parathyroids in horses, so they miss these lesions. As I said, the parathyroids are difficult to find at times. Kirsteiner cysts in the parathyroid. Typical horse change. The horse's adrenal gland begins a multinodular sort of structure, and many of these nodules remain in the adult and juvenile animal. These are not cortical adenomas, and they should not be to be interpreted as such. These are just normal anatomic variants that reflect the ontogeny of the gland. These are just normal nodules in the adrenal gland nodules. You can see adrenal gland neoplasms. Here we're seeing a slide that shows two lesions in the adrenal gland of a horse. One, of course, is this large cortical adenoma, yellow in color, typical of a cortical adenoma in any of our species. But at the same time, you're seeing areas of hemorrhagic necrosis associated with an animal that had endotoxemia. This is, again, a very typical lesion of endotoxemia in all of our species, and you're seeing a good example of it here in the horse. Cortical adenoma of the adrenal gland and hemorrhagic necrosis associated with endotoxemia in the adrenal gland of a horse. A pheochromocytoma in this horse, they're often more hemorrhagic. They're not as common as the adrenal gland adenomas of the cortex, but a nice pheochromocytoma in a horse. One more comment about endotoxemia and the adrenal gland necrosis. This obviously has got a severe lesion. The normal color of the adrenal gland would be as we're seeing down here ventrally on this section right here. And there's some severe hemorrhage and necrosis of the adrenal gland, often seen, as I said, with twisted stomachs, twisted GI tracts, ruptures of GI tracts, salmonellosis with septicemias. If you put these lesions inside a clot solution for preservative, you'll often be able to see the lesion better. Here's an adrenal gland that had been in our preservative solution, clot solution, being held for a seminar later on in the week. And when we pulled it out, we found that the area of hemorrhagic necrosis is much more visible because the free blood has gone into the solution that contained the organ, and the areas of necrosis are much more prominent. And you'll see that in hemorrhagic lesions in general in your necropsy rooms, if you put them in clots for a while, sometimes they will become more easy to see if there's a lot of hemorrhage associated with it, as opposed to some lesions that, of course, become discolored and you lose the lesion while they're stored in clots. Whenever you have septicemia, I'd just like to point out a couple of things that I see that key me into the diagnosis of a septicemia or a toxemia for whatever the cause when an animal is undergoing an acute septic or septicemic condition. In the thoracic area, it's common that you'll find areas of hemorrhage in the intercostal musculature and up over the periosteum of the ribs, up in the dorsal aspect of the thoracic cavity. Often it's bilateral, and as you see here, not necessarily symmetric. It's not as bad on this side as you're seeing here, but a very, very typical lesion of all species. Actually, I see it in cattle and sheep as well, always in this area, and dogs in animals that have got a septic condition or severe toxic conditions. In this particular horse also, it shows areas of splenic infarcts. If you look closely, you'll see them in animals who've got septic conditions. If the animal didn't die and it was put down with barbiturate, of course, you won't see these because the barbiturate expands the spleen so terribly that you miss these little infarcts. In the slides I showed you previously, I was struck by the lesions, and the lesions were all caused by, in this case, a severe endometritis. This in and of itself is very uncommon in the horse. You'll also note that it has a couple of endometrial lymphatic cysts in the center of it. This mare had foaled recently, and she had a nice endometritis, severe endometritis, and she died due to the effects of the endotoxemia and endometritis. I should warn you or suggest to you that you should never cut your adrenal glands in longitudinal section unless the lesion is obvious and you want to catch it in a certain way. Always cut your adrenal glands in the cross section, because if you don't, what you'll do, because it's an oblong lesion, if you cut through the center of it, you can be given the false impression of increased size of your medulla, whereas in reality this animal does not have atrophy of the cortex. It's just the way it was cut made the adrenal gland look as though it's got cortical atrophy. There's plenty of cortex in this particular organ. It just has a very prominent medullary area because of the way it was cut. You're looking at a very emaciated horse. He is not at all sedated. He's very obtunded by himself because he's very sick. Whenever you have an emaciated horse, of course, you always want to look at the teeth. But in this animal, we are looking at an animal with a rather severe case of acute EIA. It's acute recrudescence of equine infectious anemia virus. This animal was put down without barbiturates, and if you look at his spleen, you can see that it's a very, very enlarged and meaty spleen, and that's typical of equine infectious anemia. These animals will also have very, very prominent lymphoid follicles. Most horses have very prominent lymphoid follicles inside the spleen, but this is excessive, and at the same time has an enlarged and hemorrhagic splenic lymph node at the hilus. If the animals are not in an acute recrudescence, what you'll see is that they will have an enlarged spleen, and it'll be meaty, and you'll have enlarged lymphoid follicles, very, very prominent lymphoid follicles, again, typical of EIA. I suppose you could say it's typical of any disease that causes a chronic antigenic stimulus. But at the same time, of course, you'll have the enlarged splenic lymph nodes. And in this case, it's not hemorrhagic because it's not in the actual acute recrudescent viremic phase. Now, when I say an enlarged splenic lymph node, one has to take into account the fact that in the normal spleen of the horse, if you look for these lymph nodes at the hilus, you usually can barely see them at all. I can't really see this macroscopically from along this hilus that I'm pointing out here, as opposed to a horse with equine infectious anemia, or, as I said, an animal with a chronic antigenic stimulus, where you can see an enlarged lymph node right here. You might say, well, that looks awful small. It's small perhaps in relationship to the size of a horse, but in relationship to the size of the normal splenic lymph nodes in the horse, this is 5 to 6 times larger than normal in an animal, in this case with equine infectious anemia. But as I said, chronic salmonellosis could also do something like this. Any chronic antigenic stimulus in a horse. One should be careful when you look at the spleens of horses not to call these red foci areas of petechiation. These are normal structures seen on the spleen of the horse, the cow, the pig, the sheep, even dogs, where the red pulp actually comes through the capsule, and you'll see this in any animal. They're more prominent perhaps in animals that have got erythroid hyperplasia, as you'd expect. This is red pulp, but these are not areas of petechiation. They've been misinterpreted in a number of publications in the past, and these are just normal structures in the spleen of the horse. Now, another place where you'll see an enlarged lymph node and hemorrhagic lymph node is in the renal lymph nodes. These lymph nodes are also very, very difficult to find when you want to find them. And we're looking at a renal lymph node in this animal, this kidney, associated with this kidney, excuse me, that is 10, 20, or 30 times normal size, and it's hemorrhagic, typical of EIA. And you say to yourself, well, why would this lymph node, why would the splenic lymph node, why would and also the gastrohepatic lymph nodes be enlarged in EIA? These are all serving organs that have a very, very prominent role in in phagocytosis of immune complexes. Also, typical lesions, we're looking at the bone marrow of a normal mature horse, and you've got some foci of medullary erythropoiesis going on here. In EIA, of course, the bone marrow can be totally occupied by newly synthesized erythron in horses with EIA. Now, glomerulonephritis per se is very uncommon as a clinical entity in horses with equine infectious anemia. That is to say, you rarely ever see glomerulonephritis with proteinuria in horses with EIA. It's well described as a histologic lesion, but it just doesn't happen as a clinical entity. And it shouldn't surprise people that you're going to find immune complexes, complement and immunoglobulins and antigens in the glomeruli of horses with EIA. I don't like to consider that a true glomerulonephritis until I can see evidence of some clinical evidence in the clinical pathologic data or in the animal itself of glomerulonephritis. And you're seeing a pale kidney, a very, very pale kidney in a horse, and again, enlarged and hemorrhagic lymph nodes. And it did have, indeed, this is the only case I've ever seen of clinical glomerulonephritis in several hundred equine infectious anemia horses. Uncut section, as you'd expect with glomerulonephritis, you have a thickening of the cortex and some bulging of the cortex. And again, in the hilus, you're seeing the hemorrhagic and enlarged lymph nodes, easily 30 times normal size. As we look at these two spleens, the upper one is from a 3-month-old foal that had a Rhotococcus infection and has got lymphoid hyperplasia, and you can see all the nice foci of lymphoid hyperplasia in there, very commonly seen in horses anyhow, but in animals such as the one in this slide, it has a stimulus due to chronic antigenic stimulus from Rhotococcus. Below that, you see a spleen that looks rather inactive. You see that there's what appears to be a lot of increased connective tissue. It is really, it's prominent because there is no lymphoid tissue in this spleen. You can't see the lymphoid follicles. This is a CID foal, combined immunodeficiency foal with lymphoid aplasia down here in the bottom. Again, talking about spleens, usually secondary to a trauma and often due to being kicked and having had a broken rib. We see rupture of the spleen, they get a heme abdomen and die. Of course, when animals bleed out acutely and die, you'll also see hematomas forming inside the spleen, a lesion taught very nicely by Dr. King. And I see it also in horses that bleed out, in calves that bleed out after being castrated, dogs with hemangiosarcomas that rupture. If you look in the diaphragm, you'll see the hematomas, and that's not just blood staining, they're true hematomas inside the diaphragm. In this case, in an animal that bled out because of a ruptured spleen, this horse has been kicked and traumatized spleen with rupture and bleed out. Not all of them bleed out, some of them just form hematomas, a well-organized splenic hematoma in a horse's spleen, secondary to trauma. Hemangiosarcomas are, in my experience, extremely uncommon. I've seen, I guess, one published report of hemangiosarcoma, but I don't particularly see them at all. I've never seen one in a horse, and I believe that's a rather rare neoplasm. Here we have a spleen with an abscess. Solitary abscesses of the spleen are often associated with adhesions to the stomach, and when you dissect them away, you'll find a large swelling on one end of the spleen. And on cut section, here's a cross section of the spleen itself, a hemorrhagic splenitis, if you will, and an associated splenic abscess has been opened up. And you can see the adherent skeletal muscle here and stomach wall, gastric adhesion. Very common lesion of horses in the submandibular area. You can see this is a juvenile horse, and this is strangles. Chronic suppurative lymphadenitis of submandibular lymph nodes with rupture and fistula formation. A husbandry problem usually goes through stables that have a lot of young foals, causing a severe husbandry problem that they have to treat all these animals, clean up the area to prevent further sepsis and transmission to all the other animals. Strangles Streptococcus equi, suppurative lymphadenitis with fistula formation. Strangles should not be confused with Rhotococcus infection. The term bastard strangles has been given to solitary, usually solitary abscesses, often in the abdomen of animals that have had a streptococcal infection, presumably a streptococcal septicemia with a focus of suppurative lymphadenitis elsewhere. Here we're looking at the GI tract of a horse with large numbers of abscesses that are typical of the Rhotococcus infection, not true streptococcal equi bastard strangles with a solitary abscess. You're looking at the cross-section of a lymph node with Rhotococcus infection of the mesenteric lymph nodes, and you're looking at suppurative lymphadenitis. If this were a solitary abscess, I might suggest that it were a streptococcal one, but in the previous slide you saw the large numbers of abscesses, more typical of the pattern that we see with Rhotococcus infection in the necropsy room. However, the typical bastard strangles is perhaps better seen as a solitary abscess. It can be very, very large with adhesions to the small intestines, the large intestines, any of the viscera in the abdomen. When you open it up, what you see is a sea of pus, and this is typical of many solitary abscesses in the abdomen. Again, it is typical to have one large one with streptococcal, but you can have a solitary abscess, of course, with Rhotococcus. The term bastard strangles is associated with solitary streptococcal abscess, like this one. Not all the abscesses are so extensive in terms of their suppuration. With chronicity, they may have some healing and fibrosis and involvement of, this is a different abscess from the previous one you saw, and a lot more fibrosis and granulation tissue formation, central areas of pus. Here's the lumen of the small intestine was entrapped in this process. Again, a solitary abdominal abscess. It was cultured positive for Rhotococcus in this particular animal. So solitary abscesses can be almost any agent. The bastard strangles concept is associated with streptococcal. Rhotococcus is most commonly seen where I am, and we see it as multiple abscesses and an extensive debilitating disease. Lymphangitis and fistulous lymphadenitis is typical of glanders, where the pattern follows the track of the lymphatics right up the limb. Whenever you see this, you're dealing with some rather severe and dangerous pathogens that are often zoonotic pathogens. And in this particular case, it was streptococcosis. The glanders bacillus is also another, it would be a differential if you were in North Africa. Lymphosarcoma, there I think I see regional differences here quite a bit. When I was in New York, I saw lymphosarcoma primarily of the spleen, and I saw that with some frequency. And here's an example of splenic lymphosarcoma. The spleen is almost totally involved in this particular process. But elsewhere I've seen it as a thymic lymphosarcoma in this horse, and with a lot of frequency I see it as a GI, gastrointestinal lymphosarcoma, with involvement of the Peyer's patches in a rather prominent form. There will be some enteritis because of the debility of the animal, and perhaps a dysfunctional lymphoid system associated with it. Lymphosarcoma affecting especially Peyer's patches. There's also infiltration of the gut as well. And you'll have solitary cases of lymphosarcoma affecting the gut where I am. Here we're seeing an animal that had an acute colic because he had a hole in his small intestines. You're seeing a mature horse, and he's got ascaridge, which is rather unusual to begin with, suggesting perhaps some form of immune deficiency. But what we had in this animal besides the ascaridge was solitary lymphosarcoma of the gut. The swollen area is lymphosarcoma, and it led to ischemic degeneration of the gut and the release of ascaridge. Was this also immune deficient because of as evidenced by the ascaridge? I really don't know. We don't have good tests to demonstrate immunodeficiency of these animals, and by the time the animal comes to necropsy, they're often too late to run. There's an unusual form of lymphosarcoma, and not in that it affects the spleen. As I talked to you about before, the spleen is commonly affected with lymphosarcoma, but there are large areas of mineralization. On cross-section, you see the lymphosarcoma, but at the same time, you see these very, very white structures here that are literally hard as a rock and are very well mineralized. Lymphosarcoma with mineralization inside the spleen. Of interest, of course, is that this animal had mineralization of the aorta, mineralization of the endocardium, valves, and right up here into the atrium. And this animal had increased levels of circulating PTH, RH, and this was a case of malignancy of hypercalcemia, or hypercalcemia of malignancy due to lymphosarcoma in the horse. This has been reported by other institutions as well. Lymphosarcoma that affects primarily the skin, and only the skin actually, as evidenced by all these small nodules in the subcutaneous area, typically in middle-aged horses, and it only affects the skin, does not leave the skin to go elsewhere, and the animals are clinically normal with the exception of these nodules. And these are these are neoplasms that involve both T and B lymphocytes. Lymphosarcoma of the horse is a lot like Merrick's disease in chickens, and it seems like to be a very, very variable anatomy to the individual cells that lead to the neoplastic process. You'll have large lymphocytes mixed with small lymphocytes, mixed with cleaved lymphocytes, and they're very, very pleiotropic, pleomorphic, in their morphology. Very, very typical of lymphosarcoma in the horse, whether it's the skin or some of the forms that were described in the oropharynx in the horse about 10 years ago. Lymphosarcoma can be seen anywhere, and here was a case where they had a large lymphosarcomatous mass involving the prepuce, and it was thought that it might have been a squamous cell carcinoma, as we'll discuss later on, but on cross-section it was very, very homogeneous. Lymphosarcoma can be a very firm lesion in the horse, so if you have a homogeneous lesion, don't be surprised when you do the impression smear, and even though it's firm, to have it be just lymphocytes. Lymphosarcoma can be seen, of course, anywhere, and it can be a firm lesion. Here we're seeing an animal that's got obvious icterus. It's a young horse with icterus, and this is Neonatal Iso Erythrolysis, a mismating. Cholesterol antibodies led to hemolysis of the red blood cells, and you have severe icterus in this foal. We see it a couple times every year in the season when we're having our foals being born. One should also not be surprised if you have a severe case of Rhotococcus infection in a young animal that you might have icterus. You see the very, very swollen liver down here, and this is an animal that has severe Rhotococcus infection. I'll show you his lung later on, but I often wonder if you have such severe affectation of the reticular endothelial system, the macrophage system of the body, that you may have some dysfunction of liver and retention of biliary salts inside the body. Horses, of course, with time, if they are anorectic, they will become a little bit icteric. So mild icterus is very common if an animal has been anorectic, if a horse has been anorectic. Another example of leaving a lesion in clots and picking it out several days later, you can see better in this photograph that you've got an area of coagulative necrosis, typical of Fusobacterium infection in cattle, but this was Fusobacterium infection in a horse. And here's another area here. In the fresh state, we couldn't see it as nicely as we can see after we had it in the clot solution. Here's the same lesion when it's very, very red. If you take this section was exposed to the clots, I split the section, a section of tissue we'd saved, and you're looking at a section that was deeper in the tissue. Here you're seeing the wire that led to it. I mentioned to you how close the stomach is to the spleen and why we have splenic abscesses, and this was a case of Fusobacterium due to a wire that went from the stomach into the spleen. A colleague of mine has seen a similar case, and when I mentioned it to him, he said, did it have a wire in it? And I was rather pleased to think that there is some uniformity to the lesions seen in different areas of our country. Telogen Difluvium. We're going to talk about the skin for a while here. In the severely debilitated animal, this was a foal that had severe Rhotococcus infection, and because of the debility, the hairs no longer grow and they lose patches of hair. Telogen Difluvium. Not to be confused with typical lesions of ringworm in a horse, multifocal, well-circumscribed areas of alopecia, superficial perivascular dermatitis, hyperkeratosis, ringworm, trichophyton infection. Here we have a foal, very typical of the disease that you may have a herd of horses and a herd of foals, and only one will be affected. This is dermatophilosis congolensis infection, and we have areas of skin that look like they've been scalded. If you look at the animal a little closer, you see the typical little tufts of skin that you can pull out and make impression smears on slides and see the typical organisms on your for diagnosis. Dermatophilosis, dermatitis in a horse. Papillomatosis, again, in juvenile horses, commonly seen in large numbers of horses. It's a benign lesion, and they will go away with time, but typical papilliferous growths inside on the nose of papillomavirus-induced dermatitis. Oral plaques, they're fungating proliferative lesions on the ear. They can be pigmented, they can be white, and they resemble verrucous planum in people, and it's just a wart-like proliferation. Again, as I said, they can be pigmented or they can be plain. Seroptes in the ear of a horse, a very, very hyperkeratotic lesion. These lesions look grossly much more severe than they are histologically. The organisms live in the exudate and the upper layers of the epidermis, and histologically it's a very benign looking lesion below the epidermis. Seroptic mange in the ear of a horse. In any busy surgical service with horses, you're going to find presented to you as a biopsy. It doesn't kill animals. It's a condition that's common of the horse, and it doesn't kill, but an area that's locally extensive but not discrete, often mineralized when you look at it grossly. This is a biopsy of collagenolitic granuloma in the horse. Very, very commonly seen as in the horse, but as I said, usually in the neck area, and it is not lethal, so we see them as surgical biopsies. Collagenolitic granulomas, a cross-section of a biopsy submitted to our service. One of the more common neoplasms of the skin of the horse is the sarcoid. It has several manifestations. One that's rather unusual but seen with some frequency is just an unusual manifestation of a common lesion, is the wart-like form that we see over the limbs of horses, and this is one form of sarcoid in the horse, a neoplasm involving the fibroblasts of the upper skin of the horse. More typically, it's seen as a neoplasm of the head and neck. They're often ulcerated. I think that's probably due to trauma, not because of the process itself. In this case, probably because of the trauma of a bridle or the horse rubbing its head, in terms of it gets irritated and it rubs it a little bit more, and it's the self-perpetuating cycle of ulceration, irritation, and the horse rubbing himself. Sarcoid, typically seen head and neck. It can mimic a lot of different things when you have it near the foot. Here is one that we always wonder about when we see these things, whether we're dealing with a case of proud flesh or exuberant granulation tissue formation secondary to trauma. This one would be a differential for this particular lesion around the coronary band of a foot, but in this particular case it was a sarcoid. Another differential for a sarcoid in that particular area would be one like what you're seeing here, a severe proliferative and yet deep ulcerative dermatitis in a horse. We see phycomycosis or zygomycosis or pitheosis with some frequency in our clinic, and this is a typical lesion of pitheosis. These lesions are, as I said, they look to be proliferative. It's a fungal infection that leads to proliferation of a lot of fibrovascular stroma and, of course, the granulomatous inflammation. Often it ulcerates in the center, and if you look inside the tissues, you'll find these concretions scattered throughout the lesions inside the connective tissue of the lesion itself. If you take those out and clean them up, they are typical of the pattern of leeches or conquers that are seen inside these lesions, and they're aggregates of fungal hyphae that have multiple coats of exudate and some serum proteins, and they make these nice depositions found inside the lesions. Another differential for these sort of proliferative and deep and ulcerative lesions of the horse, particularly around the prepuce of the horse, ventral skin and prepuce, is haberniasis. It's a granulomatous infection as well to the migrating larvae of the Habernema worm, and on cut section you see cross sections of tunnels of these worms as they bore through the lesion. A vesiculo-ulcerative, superficial vesiculo and ulcerative or exanthomatous dermatitis involving the nares in a horse with vesicular stomatitis, the rhabdovirus of vesicular stomatitis. Horses get lesions around the nose and, of course, around the coronary band. Canker, a potodermatitis associated with the caudal aspect of the frog of the foot. It's proliferative, it's very fetid smelling, associated with very wet stalls, dirty bedding, and a chronic contact between the skin and dirty environment. Canker, potodermatitis of the horse. Looking in the skin around the nares of a horse, a proliferative lesion again. Right at the beginning of the respiratory mucosa, often looks like a papilliferous proliferation with little dots that look like tapioca, if you will. And this is rhinospiridiosis in the nose of a horse. fungal granulomatous inflammation in the nose of a horse, rhinosporidiosis. This is an animal with whole body dermatitis. It looks very, very severe, but in reality it's very superficial. It involves the superficial vessels. There's an eosinophilic vasculitis and hyperkeratotic superficial perivascular dermatitis in this animal. This is part of the eosinophilic disease complex, if you will, of horses that is associated with pancreatitis, eosinophilic gastritis, and enterocolitis in the horse. This is not seen very much anymore, again, suggesting its disappearance since it came with the advent of the more efficient dewormers, that this eosinophilic vasculopathy and vasculitis and dermatitis may actually be part of a hypersensitivity to perhaps strongyles. These animals typically have involvement, severe involvement of all the limbs, and also a severe coronary band infection. You can see how severe the lesion is, and I want to reiterate that as severe as it is a very, very superficial lesion in the skin. A nice vasculitis. You're looking at the anus and vagina of a mare with coetal exanthema, another herpes virus, a venereal herpes virus of horses that leads to, I think, exanthomatous or vesiculo-ulcerative eruptive disease of the genitalia and perianal region of horses with this venereal herpes disease, coetal exanthema. We have immune-mediated skin diseases in horses, as you expect. Here we have primarily mucocutaneous around the mouth, around the eyes, in this particular animal with SLE, systemic lupus erythematosus. Probably the more common or most common cutaneous autoimmune disease we see in the horse is Pemphigus Foliacious here. It appears a little bit like you'd expect dermatophilosis to look like, but this is Pemphigus Foliacious. A typical horse lesion, we're seeing a little bit of Sweeney in this animal, atrophy of the subscapularis muscle, excuse me, the subspinous muscle here. Here we see the spine of the scapula and some atrophy. But at the same time, we're seeing a capped elbow, a shoe boil, animals when they're lying down and the tail of the shoe on the back of their hoof will constantly rub against the elbow and give you this olecranon bursitis and bursal formation, actually. Common cutaneous neoplasm is a squamous cell carcinoma. It usually is ulcerative. It can be exophytic in that it can grow outward. It can be more of a deep and seemingly ulcerative lesion as well. And this is what it looks like on cut section. Reams, if you will, or streams and ribbons of this very, very firm tissue. It induces, this is the epithelial neoplasm. It also induces a lot of connective tissue. It's a desmoplastic response, a scirrhous neoplasm, and scattered inside these you will find little off-white foci of keratin pearls. As I said before, we commonly see it in the horse's skin. Non-pigmented areas, such as around the prepuce and vagina of horses, particularly is a common site of it. This is a more exophytic lesion that has also eroded away the normal structure, the end of the penis of this gelding. The sunlight reflected off the ground presumably is why we see it so often in the ventral areas of the skin of horses. Another animal we commonly see in neoplasm is the gray horse, or in my experience also the brown Arabian have a high incidence of malignant melanoma. Malignant melanoma commonly is seen first in the perianal area. On cut section, of course, is not a very difficult diagnosis. Heavily pigmented neoplasm. This disease can be extremely widespread, and here you're looking at implants all over the abdomen, seen here individually, and as these implants get very, very prominent and coalesce over the mesentery, this is the spleen severely affected. I'll show you a cross-section of that, and the liver as well, very, very heavily infiltrated. If you look at the bone marrow in these animals, they'll have severe involvement of the bone marrow cavity with this neoplasm, malignant melanoma. And again, a cross-section of the spleen, it's so dark, but the darkness is because of melanocytes infiltrating the spleen. We're going to talk now about the cardiovascular system. You can have any form of cardiovascular defect seen in any of the species in the horse, so I won't handle many malformations. Here we have an animal that had an overriding aorta, and the pulmonary artery remained as only a tag that we're seeing right here, hypoplasia of the pulmonary artery. There was a constriction here at the common outflow of both ventricles with this overriding aorta, and you have a post-constriction dilation of the aorta right here. And then perhaps more typically, we have a ventricular septal defect just below the valves, appears to involve the valves, leading to regurgitation, and down here in the left ventricle, large amount of fibroelastosis from the increased turbulence. Subaortic septal defect, aortic valvular dysplasia, and there's a fibrous band here as well, and then fibroelastosis from the increased turbulence. Another example of an overriding aorta without the hypoplastic pulmonary artery, and the overriding aorta serving both ventricles, and here is a septal defect that allows the blood from the other side to come in. With these congenital defects, the formation of ascites is to be expected in these young animals, and this is just acidic fluid in the abdomen from a heart defect. Sometimes they have these lesions in utero, and it is so severe that it causes problems inside the uterus for the fetus. And here we have a cardiac cirrhosis, a lot of varicosities forming on the surface of this multinodular liver that had, as you can see right here, a malformed heart. Here we have the atrium is as large as this ventricle right here, and we have some hydrothorax. This was an in utero problem, had severe ascites, and we're looking at blood staining of this hydrothorax as well as the acidic fluid. The distended abdomen was the cause of the dystocia, and in order to get the animal, they had to actually cut a hole in the abdomen to remove the fetus through the birth canal. They cut a hole in the abdomen, the fluid escaped and allowed them to pull the fetus, but the acidic fluid caused the distended abdomen that prevented the delivery of the fetus, with the heart defect and lesions associated with heart defect. Again, a very, very typical lesion of the horse. The horse of all the species, the only one I ever see this in, and these circular loops of distended lymphatic cysts. And again, very typical in the interventricular septum. Maybe you'll find them just a little bit off the septum one way or the other, but a loop of distended lymphatics, a very, very typical horse change, not associated with a problem, but a very typical lesion of a horse. Cor pulmonale, this animal had a chronic obstructive pulmonary disease, and we see that the right ventricular wall is almost as thick as the left ventricular wall, cor pulmonale. Horses can get lesions that we see commonly, more commonly in all the other species. Here we have a verrucous valvular endocardiosis. The free edges of this valve are thickened and hard. You're seeing fibroelastosis from regurgitation through this valve into the atrium, verrucous valvular endocardiosis in a horse. I showed you mineralization previously, but a more typical lesion in old horses, because the horse has a more conical shaped heart, the areas down lower near the apex in the ventricle will often contract to the point that they rub up against each other, and the rubbing of the endocardium, presumably in these areas, leads to degeneration of the subendocardial connective tissue, giving you severe fibroelastosis. Again, seen in old horses, deep in the ventricle, in the apex of the ventricle, but you will see some lesions up here as well. Fibroelastosis, so-called friction rubs. Verrucous valvular endocarditis, a bacterial disease. Valvular endocarditis can be seen in the horse, of course, and this is a young animal that had it, and it's affecting the pulmonary artery in this animal. You can have it valvular, or you can see it in a mural form. Here's an animal with mural endocarditis up in this area, and you have the valve leaflets down here, and they're actually very healthy looking. In an animal with a septicemia and endocarditis, a mural endocarditis. That was an actinobacillus animal. Myocardial degeneration, you can see it for a number of reasons. As in any of our species, you can see it with vitamin and selenium responsive diseases. In Texas, that's not very, very common, but in other states it's been reported. You can see it, as in this case, a slide given to me by a person who had an outbreak of horses that had monensin intoxication and severe myocardial degeneration. Here we have a case of vitamin and selenium-induced myocardial degeneration. Neurogenic cardiomyopathy can be seen in the horse, and here's a case of a horse that had a fractured back and had the area of myocardial degeneration associated with a neurogenic origin. You can see uremic endocardial degeneration as well, and any of the causes of myocardial degeneration can be seen in the horse. In years past, of course, strongile migrations led to infarcts and focal areas of myocardial degeneration. That's not seen as much anymore. Again, it used to be very, very common to see severe verminous endarteritis with actually the fourth stage larvae in it as well, and aneurysmal dilatation of the cranial mesenteric artery, a big thrombus. There are larvae in there as well. Verminous endarteritis severe. It's common now for us to see 30-year-old horses that antedate the use of ivermectin, and they will have often remodeled and much more healthy looking arteries. I presume that 10 years ago this artery might have looked like the previous slide, but indeed there is some healing possible after you get the severe endarteritis from nematodes. Again, historically speaking, it was very, very common that you would see, associated with migrating strongile larvae, infarcts of the apex of the cecum. And if you do a dissection, you're holding the wall open here, and then you see the thrombus in an affected area of large bowel. As I said, the myocardial degeneration associated with strongiles will lead to focal areas of degeneration. Here's one in an old horse, and he had an old strongile lesion. It's histologically an area of increased fibrosis and some degeneration of cardiomyocytes. Strongile-induced myocardial degeneration. The aortic thrombosis syndrome, caudal aortic thrombosis syndrome in horses described years ago, with an area of severe thrombosis of the caudal aorta and into the branches, the initial branches of the abdominal aorta. These don't always have a diagnostic cause. They aren't associated with myocardial degeneration like in the cat that has saddle thrombus formation like this, nor is it associated with something like what you might suspect, neoplasm or something of that nature, an idiopathic thrombosis of the aorta. We don't see it very commonly associated with severe diagnostic cases such as I said, neoplasms or severe septicemias. These animals are not septic, and they just had, in an idiopathic way, form severe thrombosis of the aorta. Older male horses usually will have a small rupture in their aorta with some bleeding out and escape, that is to say, of blood into the connective tissues around the base of the heart, and they'll die. This small amount of blood will be associated with a death, and it's a type of lesion that people may miss, and the hole is very, very small. Rupture of the aorta, seen in elderly horses, thought to be, by some people, related to increased blood pressure and maybe an abnormal positioning of the limbs, perhaps a fall by a horse at a period of time when they have elevated blood pressure. Rupture of the aorta and acute death. not from orexis, but because of the hemorrhage surrounding the blood vessels, presumably must impact the vagus nerve or sensors that control the conductivity of the heart. The normal umbilicus and the foal, as I mentioned, they don't get the large number of umbilical infections that we see in young ruminants and puppies and cats, for example. But when you do see periodically infections of the umbilicus in the horse, this is just not a hematoma. Of course, you can just get hematomas of the umbilicus if they pull off the umbilicus or cut off the umbilicus too short and it retracts into the body wall, and you may get hemorrhage here. But this is actually an inflammatory lesion, the falciform ligament going in that direction, the round ligaments going this way, and the urachus right here. Some of them will get a lot of extra fibrous connective tissue and an area of suppuration as well. They do get associated with a polyarthritis and septicemia condition, omphalоphlebitis, but it is nowhere near as common as seen in our other species. Arthrogryposis multiplex congenita. The animal also has a traumatic tear of the body wall taken when the animal was pulled during a dystocia. But you have the hypoplastic musculature typical of arthrogryposis. These animals are frozen in flexion. There's nothing wrong with the joints themselves. It's a problem related to the nervous system or due to the fact that the animal may actually have a condition that restricts movement in utero, and you have an akinetic freezing of the limbs. If they can't move the limbs and maintain muscle tone, they will ultimately be unable to move their limbs, and you'll have the hypoplasia of the muscle and arthrogryposis of the limbs. Again, this is not a schistosomus lesion. This was a traumatic tear of the ventral body wall during a dystocia. Typical of the more typical lesion you see with some of the viral diseases in our ruminants. Here we have another example, musculoskeletal malformation, maxillary brachygnathism. It makes the dome skull look a little bit more domed in this case. This animal does not have hydrocephalus. It was just the brachygnathism that makes it look a little bit more domed, out of proportion. Musculoskeletal malformations, again, looking at the caudal aspect of the occipital bone in this horse, you see there's some asymmetry between the condyles. When you view this same lesion from the dorsal area, you can appreciate that there's a lot of asymmetry between these condyles, a form of atlanto-occipital malformations typical of the Arabian breed particularly, but you can see it in almost any animal. You've got to look at these very, very carefully sometimes to see these more subtle lesions. You can have total fusion or other forms of malformation in this articulation, but they have all types of different forms, and this is just one of them. Occipital dysplasia in the case of an Arabian. One of the more well-characterized malformations of the musculoskeletal system is seen in foals with a valgus deformity of the carpus, and the limb has this lateral deviation. The radiographs, whenever you're doing musculoskeletal lesions, often show the lesion much better than you can see in the necropsy room, being able to pull out the pieces and save the important structures in the bone. But here you're looking at the typical lesion of the valgus malformation, and that's a malformation of the third metacarpal bone. It probably has some malformations of the fourth and the second metacarpal bones as well, but typical of what you see in the valgus malformation of the limb of the horse. An interesting lesion, if you're trying to determine whether or not a fetus or a foal, a newborn foal that dies, is premature or not, is by looking at the ossification of the carpal bones. Here we have a term fetus, and you're seeing that it has a fairly well mineralized carpal bone, whereas when they're premature, they will often have an increased amount of collagen that has not been ossified yet, and this is the carpus of an animal that's premature. Lack of ossification, prematurity. Scoliosis, fairly common of the musculoskeletal malformations, fairly common. causes are as yet undetermined, but an obvious lateral deviation of the spinal cord. Don't forget, when you describe these, that you also have to have some malformation of the ribs in order to compensate for these as well. So you have some dysplasia of the ribs to go along with the scoliosis. You have serous inflammation here over the top of the skull of a horse. This horse flipped over backwards. So you have hemorrhage and edema in the muscles on the top of the skull. But if you're careful in your examination, you realize that the animal subsequently showed central nervous system signs because of a fracture of the basisphenoid bone. Very typical of this particular trauma is fracture of the basisphenoid bone in horses that flip over backwards and hit the ground, striking with their head, the top of their head. Again, you see fractures of all kinds. This is just one example of one you might see, a Salter type 2 fracture involving the physis, but only about 2/3 of the physis. In this fragment, part is remain from the shaft remains in the epiphysis. A fracture, an acute fracture. A fracture associated with foals when they're pulled out of the birth canal, or when they're delivered out of the birth canal, and the elbow is kept up alongside the body instead of extended before the head. And this is the line of the humerus as it was held alongside the body, leading to multiple acute fractures of the rib cage in a foal. Osteodystrophy at the costochondral junction. There should be just a fine white line running along here just above the cartilage. Instead, we're seeing an extension of this white line into the shaft of the rib because of osteodystrophy, be it due to a metabolic disease, a lack of alimentation, or perhaps a severe chronic infection. In all of our young animals, one should make a habit of looking at this area to see if you have a long white line of retention of cartilage cores indicative of either nutritional or chronicity of disease, nutritional disease or chronicity of disease. Swollen maxillary bones on either side of this horse causing a rather unusual profile to this skull. In a case of Miller's disease or Brand disease, nutritional hyperparathyroidism, this is an animal given an imbalanced diet of either low calcium or very, very high phosphorus, and because of that you have fibrous osteodystrophy of the maxilla and an attempt to find sources of calcium in this animal. If you look at cross-section of fibrous osteodystrophy, this is of the maxilla, of course. You have the alveolus of the deciduous tooth here. We have a growing tooth down below, but all this is the excessive proliferation of fibrous osteodystrophy in nutritional hyperparathyroidism. Another bone proliferative lesion, an acquired lesion in a horse. This is exostosis of excuse me, the pedal bones, P1, 2, and it spares 3, hypertrophic pulmonary osteopathy. If you take the meat away from that, you'll find all the exostoses. It's interesting, it leaves the joints alone. These animals don't really present for lameness, despite the fact they have all the severe exostotic proliferation. And this is just an example of hypertrophic pulmonary osteopathy. And if you look in these animals, they're usually associated with a neoplasm of the lungs. And this happens to be a granular cell tumor, the most common primary neoplasm of the horse's lung, granular cell tumor. And that had led to hypertrophic pulmonary osteopathy, hyperperiosteal proliferation. Here is a spontaneous case of OCD, Osteochondritis Dissicans, where we have a problem in the subchondral bone that allows for a formation of a cartilage flap, and you're seeing the exposed subchondral bone here. In these two foci in the carpus of this relatively young foal. Experimentally, what we found is that similar areas are affected. This is an experimentally induced lesion here of Osteochondritis dissicans in an animal that has a high zinc diet or low copper diet copper being needed for the formation of at least lysyl oxidase, for example, and you have formation of this cartilage flap that will come up and give severe lameness. Zinc feeding buckets and so forth have been associated with outbreaks of this problem in foal crops. Osteochondritis Dissicants, usually associated with some form of subchondral problem. Now, we have spontaneous cases of this, particularly in the tarsus and in the stifle, associated with underlying bone defects. And here we have a chronic lesion in the stifle of this horse. If you then section it, you'll find that there is a problem in the subchondral bone, leading to some collapse, forming of these undulations in the cartilage, separation, obvious separation right here, osteosclerosis around it, and a spontaneous case of subchondral bone disease with secondary formation of cartilaginous flap. Now, bone cysts, again, are seen commonly near the stifle, and here's what they look like radiographically. I was expecting to see some rather impressive lesions when I looked at this grossly, because I was shown this radiograph beforehand, a nice bone cyst. Well, histologic or grossly, when you got a necropsy through them, this is what that same lesion looked like. It's not at all as impressive or cyst-like as I had anticipated as a bone cyst, what the gross bone cyst looked like. Obviously, there's a sort of fibrocartilage in here, which is not as dense as the bone. You got some osteosclerosis around it, which also allowed for some increased density when you looked at the radiograph. The contrast was elevated because of the osteosclerosis, but this is what a bone cyst looks like, not really cystic at all. Cervical stenotic myelopathy. You have to be careful and make sure that you cut your lesions right in the center of the vertebral canal. What we usually do is remove laterally part of the vertebral canal and then remove the spinal cord, and then we cut it down the middle to evaluate the size of the space where the spinal cord lies. And here we have a very narrow diameter of the space. This is not due to flexion lesion, but because the space itself is small, there was compression of the spinal cord. As opposed to this case, where whenever you bent the neck on this animal, you had instability, and the front aspects of the bodies of the vertebrae here at C7 and 6 would actually bend up into the vertebral canal, leading to a compressive lesion and cervical vertebral instability with ataxia, a wobbler horse. Now, this lesion is commonly seen with cervical vertebral instability. We have a severe loss of an ulceration, if you will, of the articular cartilage on the ventral articular surface that you're looking here. And you will see this with cervical vertebral instability with bone fragments. But be careful of not overcalling this lesion, because you'll see this in a number of spinal columns in horses that aren't associated with clinical disease. I saw it, but then again, how often do we disarticulate the vertebral columns in all normal horses? If there's no need to do it, we usually don't go through this rather laborious task. So be careful. I see these in a number of articular facets in the vertebral bodies of horses that at least aren't presented with clinical wobbler disease. Here we have a luxation. Obvious degeneration of this material as this was luxated up into the spinal canal. We have some hemorrhage around the spinal cord as well. Luxation of the spinal cord in a stallion. Lumbar spinal cord in a stallion. Also in the lumbar spinal cord, hyperostosis, osteosclerosis, some spondylosis as well, ankylosing here, not necessarily, and here as well, and almost ankylosing right there. Hip lesions are becoming more prominent, particularly in the age of the equine chiropractor, where they do some extreme abductions of limbs, and they'll actually lead to rupture of the round ligament. And here's the contralateral side, flattening of the head, eburnation, thickening of the joint capsule, villonodular proliferation, degeneration of the articular cartilage here, and a more oval profile here as this had some increased laxity, so you've had some bone remodeling as well. Exophyte, an osteophyte, excuse me, formation right here. Chronic degenerative hip disease secondary to round ligament rupture. Laminitis is commonly seen in the horse. We all see it commonly, I'm sure. This is one showing severe rotation of P3. The line is right here. The lamina should be lying, this surface should be parallel to this surface of the bone right here. What you have is increase in amount of fibrous connective tissue, hyperkeratosis of the sensitive lamina, and a prominent and permanent separation between P3 and the sensitive lamina of the hoof. This will rotate down, and here you've got actual dropping of the toe of the P3 through the sole of the foot. In acute cases, this will maintain its proximity and direction with the anterior part of the hoof wall, but there will be a lot of edema, and so grossly you see it in position, but you can press on the P3 and get free movement of it with escape of edema fluid and blood from the space between P3 and the hoof wall in acute laminitis. But when it becomes chronic, you have the proliferation of tissue here, which causes permanent separation and deviation of the angle of the P3. That will go through the bottom of the wall, and they'll rasp that off to be able to put on support corrective shoeing. But you can see here the actual periosteum of P3 as it came through the sole of this foot. Severe chronic laminitis. Nuchal ligament lesions associated with onchocerciasis, and they form labyrinthine structures in, here's the nuchal ligament, around the nuchal ligament, a very classic lesion in areas that don't use ivermectin as much as they do in Texas. And of course, in the old days, before the advent of ivermectin, we had a lot of nuchal ligament lesions from onchocerca. These little chambers, there are lots of little cavitations from where the worm would lie, the adult worm of onchocerciasis. Here's a worm right there. If you look at this photograph, you say, well, here's the lung, and right below it some colon, so you know that you've got GI tract in the thoracic cavity, and here's the remnant of the wall. I left it in place for the photograph. A rent on the opposite side with the colon into the thoracic cavity, diaphragm rupture, and strangulation of the colon inside the thorax. Sometimes it's traumatic, and sometimes it's because of a congenital hole. Here is the hole right here through which the large colon had slipped through and become strangulated. A congenital defect in this case. Exostosis, periosteitis, and myositis secondary to injections. If an injection is given outside of Viborg's triangle or given so deep that it hits a vertebral body, they commonly have these rather uncomely lesions of the neck, which are very, very, very unattractive. And this is very, very common if your needle, when you give an muscular injection in the neck, hits the bone. Depending on what you give the animal, of course, these injections can cause severe necrosis. And they were giving this horse injections to increase his stamina, and the copper injection that they gave him led to a severe sloughing of the musculature, necrosis and sloughing of the musculature. You'd suspect something like butazolidine perivascular might have done this, but this was a copper injection. This led to a fistulous problem and a phlegmon that went down the muscle layers. This is still the live horse in his stall, and it ran down the neck, down the muscle planes, and led to fistulation and draining ventrally. In the necropsy room, again separating the two muscle planes, you can see how the phlegmon moved down ventrally in the horse. In the old days, fistulous withers was very, very common, associated with harnesses and so forth. We see it now more associated with a broken saddle tree, for example, that may lead to a myositis dorsally, and following the same process it then runs down ventrally and is a very difficult infection to wall off because it enters that potential space between muscles and runs down fascial planes. Fistulous withers in a horse. Sometimes brucellosis, but not always brucellosis, will be cultured from this. We can't talk about musculoskeletal infections and diseases in the horse without talking about proud flesh and exuberant granulation tissue formation. I see it most commonly, as most people probably see it, associated with cuts of the fetlock, an old wire cut in the fetlock. If it's not treated rather heroically and with a lot of supportive care very early, this is after a year. This is all exuberant granulation tissue. Uncut section is just a white piece of connective tissue that cuts like a carrot and is nothing more than fibrous connective tissue due to a chronic stimulus from a chronic wound. Myositis due to Clostridium. Here we're looking at a locally extensive area of necrotic, dry necrotic muscle with a Swiss cheese appearance because of Clostridial myositis. I find a variety of clostridial organisms in these, so I don't know what to say to individuals regarding what causes Clostridial myositis. I have found septicum, I've found novii, chovii, but a variety of clostridial organisms associated with Clostridial myositis. You can find in the subcutaneous area a lot of foamy hemorrhagic material associated with these Clostridial myositis infections as well. Another musculoskeletal lesion, but why am I showing you the respiratory tract? This animal had a history of a month prior having had a respiratory disease. He came to necropsy after acutely forming edema ventrally and became very, very sick, and he was euthanized. And you're seeing here a severe pleuritis. Severe pleuritis. He has also got an anterior ventral bronchopneumonia. But again, all over his body, severe edema, gelatinous yellow edema here, areas of locally extensive and focal myositis, or hemorrhage at least. We'll look at those a little closer later on, but ventrally in all the limbs, a pitting edematous condition. And as I said, in the muscle, focal areas, discrete areas of hemorrhage suggesting infarcts maybe. And indeed, histologically, inside these lesions you find a vasculitis with hemorrhage associated with an aseptic phenomenon, aseptic vasculitis in the musculature, presumably due to hypersensitivity to streptococcal infections. Purpura hemorrhagica. Abscesses of the chest in the horse, presumably due to infections higher in the neck that drain down here and form these abscesses. They'll accumulate the pus there, leading to pigeon breast, a chronic-bacterial infection, rhodococcal infection of the breast when it's drained. Suppurative arthritis, polyarthritis in the horse, associated with septicemias with any newborn animal, and here you're seeing the pus inside the joint space. If you open these joints up, you'll find aggregates of exudate, some of the turbid fluid inside of it. This has been split and opened up so you can see it better. Arthritis in folds with polyarthritis. A common sequela, of course, would be the sequestrum, just necrotic bone here. You have physitis, some osteomyelitis here, as well as osteosclerosis. You have the arthritis here in the back of this joint. They had an osteoarthritis, sequestrum formation, physitis, and osteosclerosis, typical sequela of severe polyarthritis in foals. Salmonellosis is often a culprit. The distal end of this limb is very, very cold and dead. Proximally, it's vital tissue. Distal limb thrombosis in horses, seen in young horses, as we see it in our young animals, believed related to an attempt to maintain core temperature when they have a septicemia. And the limbs, here's one that's been dissected out. This part of the limb was totally cold and necrotic. Up here we're seeing the thrombosis of the limb itself with the stagnant blood from vasoconstriction. You will have ultimately some thrombosis formation, but the thrombus didn't come first. It began as an attempt to maintain core temperature. And with a stasis and the fact these animals often have a septicemia, some procoagulant activity, and you have the formation of an acute thrombus here after you've got the gangrenous limb. Looking at the croup of a horse and the very, very prominent swelling of the musculature in a myodegenerative disease. Tying up in horses is seen. I don't see it associated with the classic situation where horses worked very, very hard, is rested over a weekend and maintained on high feed, and then when they begin working the horse on the following Monday after the weekend of rest, the animal will acutely become unable to move because of muscle disease. That story is taught very, very frequently, but I don't see it very often. I see it associated with horses that have an acute onset of myopathy, swollen muscles, inability to move. They tie up literally, but it's not associated with these types of performance horses like is taught in the books. They may be horses out on pasture. They may be foals out on pasture. What sets off the myodegenerative disease, I don't know. Probably represents forms of metabolic disease that we are now going to begin to diagnose because we have the tools available to do it, looking for enzyme defects and so forth. But this was a foal that was out on grass with his mother and acutely went into myodegeneration. And the pallor of the muscles is very typical of this. They may or may not have red urine. This is an animal that was a 2-year-old and had myodegeneration all over his body. And what set it off, I'm not really certain. It happened to have rabies, but something sets these animals off. It's been described as occurring in animals with periodic hyperkalemia, and I really don't know why they get these things subsequent to some kind of a stimulus. Sometimes they are hyperthermic as well. This animal was presented with a temperature of 108, so a form of malignant hyperthermia, similar to what we see with porcine stress syndrome, may be a sign you might look for. But severe myodegeneration scattered all over the place. This happened to be the thoracic limb that I photographed. This animal had rabies. Maybe muscle fasciculations set this one off as well. But rabies, of course, is not always characterized by this. This animal probably had an underlying defect in the musculature. Typical tying up horse in an animal that is cast in his stall would present more with a more edematous lesion. The pallor of the musculature is seen here, contrasted to areas such as this, but it's much more edematous in animals that have a form of almost like a capture myopathy. Horses that are caught, fallen in a trailer and struggling for a long period of time, cast in their stall, caught underneath feed bunks and so forth. Capture myopathy as opposed to generalized myodegeneration from metabolic disease such as the polysaccharide storage disease recently described. They are different syndromes. Multiple cartilaginous exostoses in the horse, seen commonly on the ribs, of course. On cross-section, it's a very unexciting lesion in that you have increased cancellous bone, and the proliferative lesion is occurring underneath a cap of cartilage that's retained here and just keep proliferating. Multiple cartilaginous exostoses, a genetic disease of the horse. Firm structures growing usually in young animals. This is typical of the ossifying fibroma. They are not odontomas. They are, as in this case, here's the lesion. It was on the mandible down below, and the teeth are way up here, not associated with teeth at all. Ossifying fibromas, a fairly common lesion of the bone. Here is one associated up in the maxilla, not associated necessarily with a bone, as I said, with a tooth, as I said, but an ossifying fibroma. We're going to talk about the renal system now, and typical, what we should expect to see in a horse with horseshoes is a horseshoe kidney. The left and the right kidney are fused together in the center of the body, forming one kidney, a horseshoe kidney in a horse. Congenital malformation of the kidneys. Polycystic kidney disease, I've seen this happens to be in a foal, but I've seen similar kidneys in a 22-year-old horse that died because of a totally unrelated problem to the kidneys. And polycystic kidney disease. In the horse, it's much more typical that I see them with lots of very, very small cysts instead of a few large cysts. And the outer cortex is affected with these cysts. Fairly recently, it was described a cystic disease of the kidneys of horses associated with sulfur administration to the pregnant dam, and the foal being born with cysts. This particular case had no association with sulfurs in the pregnant mother, so I consider it a case of spontaneous idiopathic polycystic kidney disease. Not a lethal condition again, but seen as multiple cysts with lots of extra parenchyma to provide renal function. Polycystic renal disease. Another newborn renal or urogenital system problem, the patent urachus. Here's the urinary bladder and the urachus, and this animal was born with a patency of the urachus. Necrosis of the cortex of, in this case, a foal that was giving heroic doses of glucose. The animal died and had a rapid degeneration and necrosis of the cortex. Not a cortical necrosis from hypersensitivity like we see with a Schwarzman's reaction. This was just rapid autolysis and degeneration of the kidney post-mortem due to death while it has a lot of glucose. When you look at the kidneys of a newborn foal, you have to be a little bit careful. They are pale. They will look like they bulge a little bit. This is a normal kidney in a foal. However, in foals, you can get a pallor and swelling due to aminoglycoside. And when you see that, the pallor is usually isolated to the outside aspects of the cortex. This is indeed a nephrosis due to aminoglycosides in a foal. There is pallor, but be careful not to confuse the pallor of the normal foal with a pallor of a true nephrosis. This is an aminoglycoside nephrosis. In the pelvic crest, you're seeing here areas of discrete green-brown discoloration. Because of renal crest necrosis, it will become discolored. The necrotic tissue will maintain the color of the hemorrhage, and you'll get the breakdown pigments giving you the green color. The green is not because of the drug. The green is the discoloration of the dead tissue in a live animal with blood pigments. Renal crest necrosis from butazolidine intoxication. Any of the NSAIDs drugs can do it. Arabian horses have a condition. The desert-bred Arabian horses have a condition that lead to acute medullary necrosis. It is, as you're seeing in this photograph, a severe lesion with scalloped areas of necrosis of the medulla. They will break through and give a subcapsular hematoma as well. You'll look in the cortex and you'll see that there's retrograde flow of hemorrhage. It'll undergo the blackening of pseudomelanosis. This was a surgical specimen. This is not a post-mortem change, this blackening. And again, you'll have the subcapsular hemorrhage in Arabian horses with this acute renal crest necrosis syndrome. Only in desert Arabians, presumably due to their ability to concentrate urine under periods of water deprivation, and while they're sick, they will get these acute areas of necrosis. They will be presented with life-threatening hematuria, desert Arabian renal crest necrosis, severe necrosis. There are a number of nephroses in the horse besides antibiotic, and a couple examples that we see spontaneously. You're seeing here a rather olive green kidney from silver maple toxicity. In the northern states, you see it associated with red maple. This is one due to silver maple toxicity, and you're looking at the off-color kidney because of the hemolytic process and the subsequent hemoglobinuric nephrosis. We also see it associated with oak toxicity, and here we've got a section of a kidney from a horse. It's got swelling of the cortex, and you're seeing a little bit of discoloration. This kidney was tremendously swollen inside the carcass, and of course we found acorns inside the large colon, fragments of acorns this animal had been eating. Oak nephrosis in the horse. The tongue here shows a couple of lesions. Some lesions, we're talking about the renal system, and we're looking at ulceration of the tongue of the horse due to the typical lesion of uremia, and also bilateral lesions of the tongue, uremic glossitis. At the same time, there's a circumferential area of necrosis we see in horses that is said to be due to either the tongue being tied by the trainers when they're racing, or when they're in training, or some people say they may be due to very, very harsh bits. So I want to just talk about this for a moment. And if you're talking about a harsh bit, here we have a cathedral correctional bit used by some trainers, and that may be associated with what leads to the necrosis of the tongue. It's either due to being tied off, because it's just a focal area of myodegeneration and necrosis, or the use of a bit like this perhaps, as opposed to a much more benign bits for use. This of course would be used with a light hand on a horse because that can cause some tremendous damage, but that circumferential necrosis of the tongue is a rather neat lesion seen in the horse. Back to uremia, here we're seeing severe uremic gastritis in a horse. This was that horse that had the oak bud nephrosis, lots of necrosis inside the tongue, in the stomach, hemorrhage, a uremic gastritis. And as I mentioned before, in the myocardium of these horses, these pale areas of myocardial degeneration are seen in horses with the severe ionic disionic situations where they have high potassium, low calcium, high phosphorus. Whatever the contractile problem is, it's related to those ions, and we have the myocardial degeneration associated with it, seen in uremias in all of our species. Here's a rather complex photograph, but it's nice to use to think about because we have hydronephrosis, hydroureter, hydronephrosis, and the kidney remains as just a flaccid sac from severe hydronephrosis and degeneration of the renal tissue. Here's the bladder and round ligaments here, the other ureter, and a compensatory hypertrophy and hyperplasia of the opposite side kidney. We see a large number of spontaneous renal stones. Here's one here, with a dilated ureter down here as well. The kidney is mal-shaped in that the cranial part of the cortex is also lost. I often wonder if there's been some necrosis, perhaps used due to non-steroidal anti-inflammatory drugs that cause a formation of a nidus on which these concretions can form. But renal stones are fairly common in horses, with perhaps a slight increase in occurrence in the Arabian horses where we are. They'll form these stones that are mostly oxalates and have a papilliferous appearance, almost staghorn appearance in form, but again, a collection of stones taken out of a horse with renal calculi. An infarct in a horse, polyhedral edges, sort of straight side edges, hemorrhage in the center and some pallor at the edges. And if you cut the section correctly, you will see a typical wedge-shaped lesion, renal infarct, for the same reason you see renal infarcts in any animal. Septicemia is very common. You can see perhaps a little bit of extra hemorrhage inside the glomeruli of this animal who is in DIC. Multiple embolic phenomenon in septicemia is common in the horse, particularly in the case of shigellosis, Actinobacillus equiruli, shigellosis foal, a classic photograph of embolic nephritis from septicemia in young foals. You can see emboli from a number of agents. This one is due to fungal infection, aspergillosis in the kidney. And they are larger. There's more granulomatous inflammation here, of course, and on cut section, irregular areas and not as discrete as true infarcts, and due to, again, granulomatous nephritis from aspergillosis. And the third one I want to show you is typical of haloblacephalus. We used to be called Micronema deletrix, haloblacephalus, large foci of granulomatous inflammation that contain, of course, many, many small worms of the Haloblacephalus deletrix, granulomatous nephritis. Now, inflammation of the kidney in young animals with leptospirosis, severe interstitial nephritis. This is a newborn foal. You can see it in utero, in abortions, but leptospirosis in an opened up kidney in a foal. With chronicity, you will see, just as you see with dogs with chronic leptospirosis, the chronic nephritis, chronic interstitial nephritis in these animals with chronic leptospirosis. And they will also have, up here at the top of that kidney was an acquired cortical cyst. A lot of infiltrative looking lesions here, along here, indicating the lymphoplasmacytic interstitial inflammation seen with chronic leptospirosis. Neoplasms of the kidney. Here is a focal adenoma on cross section. It's a nice lesion. We see much more frequently carcinomas. And here's an example of one of the carcinomas. The animal had severe hemorrhage into the pelvis, some retrograde bleeding here that led to a nephrosis as well, a thickened cortex, but neoplasm down here. Renal carcinomas, adenocarcinoma. Photograph of the parenchyma being replaced by a proliferation of neoplastic tissue. Here's another one. All that remains of normal kidney is at this edge right here, and this neoplasm, this adenocarcinoma, was the size of a large ball, like a basketball. Typically, it becomes embolic to the liver. Here we have one, the renal carcinoma associated with the lesion that led into the vena cava and went into the liver, metastatic adenocarcinoma. Here's a severe adenocarcinoma with just a little bit of renal cortex left, and it had formed a calculus as well. Rather interesting slide. Here we have the bladder of a horse, and it's got neurologic disease, typical of whenever you see spinal cord disease. And the bladder here has got apical necrosis. Because it cannot urinate, the bladder will get distended, and you'll have necrosis of the apex, and ultimately you'll have the urine break out through a hole in the apex of the bladder. Here's a bladder of a horse that also had neurologic disease, but what you're seeing, he hadn't ruptured his bladder so much as he had such a poor urine flow that he had accumulation of the concretions from the mucus secreted in the urine of horses, and it'll form a sand in the bottom of the bladder. This is not cystitis, this is just accumulation of that urine detritus. When you have got cystitis, you don't necessarily have that because the bladder is hypersensitized and they secrete their urine more often. You don't necessarily see when you have a cystitis that concretion of material. This is a case of cantharidin toxicosis, cantharidin-induced cystitis. When you have disease of the urinary bladder, such as a transitional cell carcinoma, it may induce problems in urinary emptying, and again, you'll see that detritus scattered over the surface of the bladder. The liver. This is a case of Tyler's disease, serum hepatitis, where you have massive necrosis of the liver, and you have what's been described in the past perhaps as a dish rag liver. And this shows how in a fresh necropsy, the liver has no strength at all, and it almost looks like an amoeba moving along the surface of the necropsy table here. It's Tyler's disease, serum hepatitis. Here we have a liver with severe lipidosis. Pregnant mares, also mares that have are crosses between ponies, pony crosses and the hyperlipidemia syndrome of horses. This particular animal has the hyperlipidemia syndrome. The serum was always full of lipid, and it had hyperlipemia and liver lipidosis. Lipidosis can get so severe as to make the liver fragile and fracture, and you can get orexis into the abdomen. Hyperlipidosis, lipidosis of the liver. Hepatic congestion from heart disease. Here we're seeing a nutmeg liver pattern in this liver, typical of chronic passive congestion, and you can see it in the horse as well as any of our species. Perihepatitis filamentosa, again a lesion typical of the liver of the horse, where you've got the formation of these little fibrous tags on the parietal surface between the liver and the diaphragm in most horses. These lesions can be more focal and have like plaques that remain, they're just superficial on the top of the liver, don't extend to the parenchyma. Some people believe these are related to parasites. When you see lesions like this, it's hard to believe a parasite gave rise to that. Something led to organization of fibrin on the surface of these liver capsules. Again, typical lesion of the horse. Embolic suppurative nephritis, seen in septicemias, and here you're looking at the typical foci of suppurative hepatitis through the capsular surface in a foal with a Klebsiella septicemia. On cross-section of the liver, these multifocal foci of necrotizing and suppurative hepatitis in a septic foal. When you have massive septicemia with lots of necrosis and hemorrhage on top of it, a lot of these foci are hidden. Here you can appreciate some of the foci. Here it's hidden by some of the hemorrhage and the necrosis in the liver. Another foal with severe Salmonella septicemia. Different organisms can cause different forms of necrosis. This would be a nice area of coagulative necrosis, typical of what you see with Fusobacterium in cattle. In this case, it's due to Clostridial colitis with embolic foci to the liver. Some lipidosis as well, but these dry areas of necrosis, typical of bacteria that form severe toxins such as Clostridium or Fusobacterium. Locally extensive necrotizing hepatitis. When you have chronic salmonellosis, the lesions change a little bit. Again, you're looking at those perihepatitis filamentosa foci, but these little foci that look like abscesses indeed are microabscesses in chronic salmonellosis. When you make a section of this liver, what you see is that, sure, those multiple foci are still visible, but there is a linear nature to these inflammatory lesions as well, as it's following the portal tracts, giving you chronic cholangiolar hepatitis, pericholangeal hepatitis, and microabscess formation, chronic salmonellosis. This liver has a very characteristic appearance. It's kind of dark. It's got a lot of little white foci that you can't appreciate, but the livers with this particular condition always look like this. On cross-section, it's much more easy to see the lesion. Massive numbers of little foci of granulomas from massive parasite ascarid or strongylus migration, mineralized foci, parasitic granulomas, and lead to the overall appearance that I showed you in the previous slide. Echinococcosis in horses, multilocular lesions. The wall is a granulomatous inflammation. Once these parasites die, echinococcosis of the liver of a horse. When you have chronic liver disease that follows a solitary severe insult, you get nodular liver, a hobnail liver, increased amounts of fibrous connective tissue, a post-necrotic scarring, typical of a post-necrotic scarring from a one-time massive insult. If you have a chronic type of lesion, the overall format of the liver looks the same. This is a little bit off color, maybe to the green side, and throughout the liver there's massive involvement of a single area of the liver, the portal area here, and it gives you a different appearance from that post-necrotic scarring liver I showed you. And here we have a lesion that could be it's been published as alcyte clover intoxication, but some form of toxin that acts on the periportal area, so you have a uniform distribution of your liver lesion. We see it like this with and without choleliths. Cholelithiasis is fairly common in the horse down where I am, and we find it associated with these biliary, the biliary cirrhosis. Now, does this lead to the biliary cirrhosis, or did biliary cirrhosis lead to stagnancy of the bile and the formation of the stone? I don't know, but we do see this biliary cirrhosis often associated with stones. Adenocarcinoma of the liver, very, very uncommon. What we see more commonly in the liver is lesions of the cholangial system, cholangiolar carcinoma, or metastatic neoplasms like the renal carcinoma or lymphosarcoma of the liver, metastatic neoplasia. There aren't very many conditions of the pancreas in the horse that we can describe. If you have strangile edentatus migration, they will have formation of granulomas in your pancreas. We talked about the eosinophilic dermatitis, vasculitis complex, if you will, of the horse that you will have. This is the cross-section of a pancreas showing areas of there's some mineralization, lots of bile duct proliferation, lots of eosinophils in these animals that are probably representative of a strangile hypersensitivity eosinophilic syndrome. And rarely a chronic pancreatitis with lipidosis of the liver. Not very often seen, but as you'd expect, chronic hepatitis with an endocrine insufficiency could lead to a fatty liver, as you're seeing here. Going to the respiratory system, let's talk about the sinuses for just a really brief moment. A nice suppurative sinusitis in this horse, presented for CNS signs. It had actually gone through the sinus and into the brain, but the root of the problem was a chronic sinusitis from a tooth disease. Sinusitis or formation of a rhinitis, accumulation of exudate for a long period of time, can give you a lesion such as this, and here we have just a concretion of the pus from the chronic rhinitis sinusitis. This area of the horse is an important area to think about because at this angle behind the soft palate we see proliferative inflammatory lesions of various forms. You can have your progressive hematoma that are very, very hemorrhagic, lead to epistaxis for a long period of time. Histologically, you'll see fibrosis, hemosiderin-laden macrophages, vascular proliferation, and you may see cystic glands. But we see these polyps very, very frequently. The clinicians, when they're looking through an endoscope, this is not a very well-focused lesion, but that's what they're looking at when they're looking through the endoscope. And this is a polyp, a lot of mucus hanging off of it, and this is what the clinician sees. And this is, in that particular case, this is what he presented me with. They were able to surgically extract, this is a centimeter marker down at the bottom, this multinodular polycystic lesion that has lots of mucus in it. These are inflammatory polyps, again, taken from that very typical area near the back of the soft palate in the horse. We also see them associated with localized infections in that area. Again, here it is, and this was a streptococcal abscess. And yet another one associated again in that same angle that we're talking about right here behind the soft palate, and this was Coccidioides immitis. Coccidioides immitis in a horse in this angle. This is an important area to remember. Besides just the progressive hematoma, we have inflammatory polyps forming there all the time. Along the nasal septum is a surgical biopsy of eosinophilic rhinitis, an allergic rhinitis in a horse, just like you would see with heliotropism, a heliotrope in cattle. I'll change carousels now. Oh, excuse me. I'm sorry. Some more lesions. Here we have the soft palate. The condition of elongate soft palate is a very difficult thing to take a photograph of in a necropsy room. However, the other form of soft palate entrapment of the glottis is shown very nicely here. It's thought to be due to either a hypoplasia of the glottis or a redundant mucosa below the glottis. And this is the pharyngeal mucosa right here, and is riding up over the rim of glottis of this horse. And you have ulceration of it as well. Glottis entrapment. If you remove this fold, you can now see the epiglottis, and all that redundant the redundant oropharyngeal mucosa is down here. And of course, typical of the horse, hyperplasia of the lymphoid follicles in the oral mucosa should not be worried about. And this condition is seen in older horses, the so-called scabbard trachea. And it's a V-shaped trachea on cross-section, and it comes from a defect here where it becomes weakened, and it folds over and almost closes up like a book, as opposed to the normal tracheal ring that is like this, usually occurring at the tracheal entry to the chest in the anterior aspect of the thorax, the caudal aspect of the chest, and it forms a V-shaped trachea that almost look like you could run a sword down into it, hence the name scabbard trachea. Laryngeal hemiplegia in the horse is, of course, due to a problem with the recurrent laryngeal nerve. So you have left side laryngeal hemiplegia, and you're looking at the left side here where you've got a malformation of the rim of glottis. The glottis, you can see here, is tipped, and you have hypoplasia of the muscle here because of neurodegeneration. Roarer horse has a stertor when it breathes, and it's because of the laryngeal hemiplegia. Typical of horses with long necks, racing horses also. Various types of pneumonia. Typical of viral pneumonias, the appearance you're seeing here, the purple, red areas of lung where there's very little aeration, contrasted against the more light-colored areas of aerated lung. Adenovirus pneumonia. This is in a CID fold. On cross-section, when you look at these, you see that the lesion has sort of a off-white appearance associated with the bronchioles and bronchi, and you can look at these things, and there are areas in between where you begin to see a more yellow-looking lesion as suppuration accumulates, but this gray area that is typical of the proliferative and necrotizing lesion of chronic viral pneumonias, adenovirus pneumonia, again seen most frequently in the combined immunodeficiency foals. With time, these animals will get bacterial infections superimposed on them, and this is an adenovirus pneumonia with some superimposed bacterial infection. Again, you can see in these things the foci that are more gray-white here, centering on the bronchioles, but the other areas that are more typical of a suppurative infection around it. Here we have a lung that did not collapse at all. You've got an obvious pleuritis. It looks rather hemorrhagic. You remove the lung, you see that that lung is affected primarily on one side, and this is gangrenous pneumonia and pleuritis. This animal had inhaled a piece of wood, and the entire lung is dry and necrotic. It's like a big sequestrum. Sometimes the lesion is not that severe, and you have focal areas of necrosis, and they heal, and you'll have like focal areas of liquefactive necrosis that fill in with suppuration, and you get lesions that look more like this, gangrenous pneumonia in the subacute stage. We will see adenocarcinomas, adenocarcinoma of the nose, usually affecting the ethmoid turbinates and extending anteriorly, adenocarcinoma of the nose. Pleuritis, severe pleuritis, a lot of extra fluid, empyema, if you will, of the thorax. And when you look at these cases, you have to remember that there are cases where there is just pure pleuritis. Pleuritis might occur from a rupture of a lung abscess. It might occur from a transthoracic insult, a lesion that goes through the esophagus, a lesion that runs down into the cupula of the lung from a neck injection. But you can get just pure pleuritis with no bronchopneumonia. So not all pleuritis leads to bronchopneumonia or is secondary to bronchopneumonia. That was a pure pleuritis. Anterior ventral bronchopneumonia transport pneumonia, shipping pneumonia in horses, typically seen. We get a lot of streptococci out of them, and it's typical of horses when they die 2 or 3 weeks after being transported, sold and transported, or during the competition seasons. You're looking at here's the teeth over here, the medial muscles of the maxilla, and you're looking in the guttural pouch with a big hematoma. Fungal infection with vasculitis, rupture of the vessels, and rhexis with massive hemorrhage out the mouth and nose when they lower their head. They'll inhale a lot of blood. Here's a lung with inhaled blood in it from an animal that had rhexis from the guttural pouch and usually the internal carotid artery that gets ruptured. With chronicities, these fungal infections that don't hit the blood vessels will look like this, and they have proliferative lesions, a thickening of the membrane of the guttural pouch. The guttural pouch membrane should be purely transparent, and you should be able to see the color of muscle through this. But when you have chronic infection, you have a thickening, hyperplasia of the mucosa, and it doesn't look like a normal mucosa, obviously. You can have accumulation of suppuration inside the guttural pouch, secondary to strangles or streptococcal infection. You can pull that out and see again that the mucosal membrane, the mucous membrane, is not transparent, and you'll have the formation of these little stones that are accumulations of pus. Accumulation of these pyoliths or chondroids can be fairly impressive. These fell out of one guttural pouch in a horse that was killed for a total other reason, had a chronic infection, and maintained those stones inside the guttural pouch for probably months to years. Lung in a newborn foal that does not collapse, and you can see the rib impressions here. You can see an enlarged liver. This was due to equine herpes virus infection in utero. Gives you a nice pneumonia. You may have an accumulation of detritus in the trachea as well in a newborn foal that dies due to equine herpes virus 1 or equine virus abortion. It's much more common, however, that you'll see these foals with large lungs and rib impressions due to meconium ingestion following a dystocia in utero stress where they swallow a lot of the detritus and the meconium. These things may become discolored yellow because they will actually defecate into the allantoic cavity, and that material will be swallowed by the foal, and the meconium being yellow will sometimes discolor this to be yellow. But the rib impressions are very typical here, and they will inhale so much meconium that they will have a lung that cannot deflate. This is typical of the maladjustment syndrome in foals, and they may live for a short while, and you'll have aerated lung, but most of the lung is non-functional because it's full of this detritus, meconium ingestion. On cross-section, it's very unimpressive. You can't see patterns of any of the structures. They're just sort of full of this inert material, and it's not an inflammatory lesion. An enlarged lung, it looks almost like a lung that's got alveolar emphysema. There's not a lot of hemorrhage to it. And this is typical of a lung with pneumocystis carinii infection. They have edema, and all the alveoli are distended by that very, very fine fibrillar material that's typical of pneumocystis, but it's not a very inflammatory lesion, so the lungs have a sort of a characteristic appearance. Another large lung, it did not deflate. You begin to see some rib impressions. Certainly you see some edema, distended lymphatics on the surface, and maybe a little of anterior ventral consolidation. This can be a very impressive lesion, and what I'm talking about is bronchointerstitial pneumonia of adult horses. I will call it idiopathic in that no one really knows what causes it. A number of etiologic agents have been suggested but not proven. Again, the rib impressions, these lungs stay up and inflated when you see them as well. Distended lymphatics. There may be some consolidation as you'd expect with chronic disease. There may not be total efficiency of the immune defenses in the chronicity of it, and these animals are ultimately euthanized. They can be really severe, large areas that seem consolidated, some very, very little areas of aeration. The trachea you can see here is very, very dark red from the dyspnea. And on cut section, you can have areas of consolidation, as I said, some aeration, but a chronic bronchointerstitial pneumonia. Nobody knows what causes it. I mentioned this, that it was Rhotococcus pneumonia. You can have a yellow animal. This is not a poorly exposed film. This is a very, very icteric animal I showed you before with a big liver in a fairly young animal, lots of abscesses from Rhotococcus infection. And does the increased yellow from this animal come from the fact that there's some compromise of the RE system for maintaining hepatobiliary or recirculation of bile pigments? I don't know. But you will see a yellow animal, and you'll see these abscesses in the lungs. Sometimes you have the formation of large abscesses. Here's another small one up here, another small one here, but much of the parenchyma seems to be normal. Some atelectasis right here. On cut section, you'll see abscesses, other areas that are beginning to be consolidated, or just total lobes of lung affected with this pyo or pyogranulomatous bronchopneumonia. This lung is large, it didn't deflate, but it looks like normal lung. You might expect that there might be something obstructing the trachea, or this is a case of chronic obstructive pulmonary disease, alveolar emphysema with animals with chronic hypersensitivity pneumonitis. The lung is very, very soft, it's crepitant, and it feels like a piece of chiffon. And this is an animal with alveolar emphysema, that form of heaves that has chronic broken airways from chronic coughing from alveolar emphysema and hypersensitivity pneumonitis. In active phase, you see the mucoid bronchiolitis. And here you're seeing again that pattern of sort of gray foci scattered through the parenchyma where the lesion is emphasized on the bronchioles. The only histology slide I'm going to include in my presentation showing you that indeed there's exudate and mucus inside the airways here, in a multifocal pattern. The alveoli themselves have got some broken walls and some large chambers, but they don't really form a very, very important part of this disease if you look at the lesion critically. Mucoid bronchiolitis heaves. Influenza will have areas of consolidation, but because these animals are breathing with such dyspnea, you'll see a lot of alveolar emphysema and pale areas of lung, as well as areas that are more dark and consolidated. Influenza. On cut section, there will be areas of consolidation, but you will see areas that are more aerated. This animal was so dyspneic that indeed he actually ruptured the blood vessels and ultimately died from bronchospasm from intratracheal hemorrhage. Septic lungs, when you've got a massive septicemia, can give you an interstitial pneumonia. Here is a young animal with interstitial pneumonia and almost a collapsed looking lung from total consolidation, but massive microemboli all over the place. If there's more aeration, you can begin to see on cross-section these little hemorrhages, each one representing not a DIC focus, but a focus of an embolic shower to the lung in a septicemic fold, typical of septicemias, especially salmonellosis. If they live for a while, the lung will become hard, well, not hard but firm like a piece of liver, will cut like a piece of liver, and you'll find massive dissemination of these foci of suppuration from salmonellosis and embolic salmonella lung. On X-ray, radiographs showing a density here in the center of it. This was biopsied, and they found fungal hyphae, and they didn't know how to understand it. But it's really well understood because it's a typical syndrome of the horse, often associated with an infection elsewhere. The one that we showed you previously was a uterine infection, but this is one that I saw associated with a salmonella infection, and the animal had been treated with antibiotics for a while, and he became acidotic with a diarrhea and set up the stage for a nice embolic phenomenon with fungi. And these red areas are emboli of fungi. They have a vascular tropism, an angiotropism, so that they will lead to hemorrhage in these lesions, acutely severe hemorrhage, and the individual lesions will look like hematomas, embolic mycotic pneumonia. Histoplasmosis is uncommon. We will see it. Massive dissemination of, well, this looks a lot like what you'd see with Rhotococcus, but in this case it's pyogranulomatous due to histoplasmosis, pneumonia in a horse. Chronic interstitial lung disease in the end stage looks like this. There are areas of aeration and emphysema and areas that aren't as aerated, and they will collapse. What you see on cross-section are large areas of fibrosis, often following the bronchial tree in the end stage of bronchointerstitial pneumonia. And again, we don't know what causes it, but we have to admit that it certainly makes a beautiful lesion. Some respiratory syncytial virus has been found in animals dying with bronchointerstitial pneumonia by PCR reaction, and maybe it is an organism that we will be able to find as we have more diagnostic tools to look for them. RSV, arteritis virus has been known to cause pneumonia in horses, maybe a form of influenza virus, and with PCR we may be able to test more of these cases as we see them. Areas of mineralization of the apex of the lung lobes associated with vitamin D intoxication. You might also think about it in terms of if the animal was in renal failure, uremic mineralization of the lung. But this one was a case of vitamin D toxicosis. Pneumonia, I showed you this lung earlier with granular cell neoplasm, the primary neoplasm of the lung. It can be large, but often that's a large one, but you'll find a lot of small ones in here. It's a multicentric neoplasm in the lung, granular cell tumor of the lung of the horse, the most common primary neoplasm of the horse lung. Metastatic neoplasia, in this case, to the lung and liver from a renal carcinoma. This is what we see more commonly in metastatic neoplasms. Reproductive system. I'm going to talk about conditions that are typically equine. The horse has a series of lesions that you should understand very well because they have some idiosyncrasies to their reproductive system. The placental or cervical star, an area where the animal did not have a chance to implant its placenta. The chorion was laying up against the cervix and there is no implantation there, and it makes this nice pattern of a star burst, if you will, the placental or cervical star. A normal structure. You should be able to identify this because in cases of infections, that's where the infection comes in, through the cervical os, and so the infection will lead to a suppurative placentitis, and it will extend from the star in a radial pattern, and you'll find areas of a discrete border between normal placenta and placentitis in the mare. Now, if you look on the opposite side of the chorioallantois, on the opposite side had a chronic infection. On the side, you're on the allantoic side of the placenta here, you're looking at this thickened area, nodular area, underneath the placenta. And this is cystic hyperplasia of the allantoic glands. Again, seen only in the horse, seen associated with chronic inflammation of the placenta. Here we're showing you some edema as well. Cystic allantoic glands associated with chronic placentitis, and also here we're seeing some edema, perivascular edema. You are looking at the placenta from the allantoic cavity here, as opposed to looking at it from the uterine surface here. Why do twins often abort? Why does one die and the other not? Here we have twin placentas from a horse, and here is where there was contact between the placenta and the uterine wall. However, where the fetus was butting up against its brother or sister, the placenta does not have a chance to come in contact with the uterine lining, and so you have no placentation or no formation of chorionic villi. And here you're looking at that closer. The villi are formed here, an area of lack or losing of the villi, and an area where there are no villi in a twin placenta. Here we have a very circular lesion of very discrete, somewhat linear structures, and we also have this cystic lesion here and another cystic lesion here. Endometrial cups typically form a ring where the trophectoderm form, and then lymphatic cysts in the endometrium, very, very common in old mares. These are typical of the placenta of the mare. You can see them between 70 and 120 days in the endometrium of the uterus, the endometrium of the mare. Obviously, it has to be in the uterus. These cysts, these lymphatic cysts, are very, very common. They can be transmural. You're looking at the serosal surface here, and a large lymphatic cyst that is transmural in this mare, others that are just on the endometrial surface. Lymphatic cysts. Another typical horse lesion in the uterus, you had opposite this pouch the endometrial cups that we talked about, the formation of those endometrial cups that form that circle I showed you 2 slides previously. They will form a secretion that will form a pouch that will form a long stalk. You're seeing another stalk along here. More stalks in these pouches. They are commonly seen around the umbilical stalk as well, because that's where the umbilical stalk attaches. The umbilical stalk attaches right in the middle of those endometrial cups, so that you will have a ring of these chorioallantoic pouches where they form opposite the endometrial cups. So endometrial cups give rise to these chorioallantoic pouches. Again, typical of the horse, because the horse of all of our species is the only one that forms the endometrial cups. So you will only find allantoic pouches in the horse. Hippomanes, concretions of detritus in the allantoic cavity that is compressed like a pancake between the amnion and the allantoic membrane, and you'll get these very, very rubbery concretions floating in the allantoic cavity ultimately. Hippomanes. Yolk sac remnant, they are only seen in the horse to my knowledge, and these are mineralized concretions that come off a stalk on the umbilical stalk of the horse. These are not moles. These are not monsters. They share the same placenta with this fetus, obviously, and they are mineralized yolk sac stalks. Here's the umbilicus, and it comes right off that. Very, very small ones can be seen in most umbilical stalks of horses. They get big and mineralized, and they're hollow if you cut through them. Mineralized, they will often be hemorrhagic, but there will be nice bone formation, medullary, or there'll be extramedullary hematopoiesis in these structures as well. As you'd expect, the yolk sac is a form of origin for much of the erythron in the fetus. Rupture of the vessel wall, the body wall of a mare in dystocia without rupture of the prepubic tendon. Very rarely does the prepubic tendon actually rupture. These cases are diagnosed grossly by the clinicians as of rupture of the prepubic tendon, but the prepubic tendon is the last thing that survives here. This is the prepubic tendon below this skin, and all the body wall around this ruptured. This was a horse who was in a dystocia, found in a field with a foal half in and half out, and what happened here was the foal had crossed its leg over the opposite stifle and got locked in the pelvis, leading to straining and rupture of the body wall, not the prepubic tendon. Pseudohermaphrodites seen in horses. This is a male pseudohermaphrodite, not because of the formation of a penis, but because it was a genetic male. The problem with the penis was that there was a lack of testosterone receptors, so there was no proper development of the structures of the urogenital sinus. Pseudohermaphrodism, an intersex, a male intersex. A large neoplasm of the ovary in the mare, very, very common, granulosa cell neoplasm. It's very, very large enough for a meat inspector's helmet to be on, my inspector's helmet, and here we're having a granulosa cell tumor that weighed over 17 kilograms. They are large on cut section. They're cystic, lots of cysts in them, a nice thick wall. I've never seen one become malignant, a benign structure, but they are large and lead to problems. They can get so large that you can have necrosis and hemorrhage in the center of it. This area is undergoing ischemic necrosis as well, and with time they compromise their blood supply enough that they will undergo involution. A necrotic granulosa cell neoplasm still maintains a couple of cystic structures in it, But on the wall, if you do lots of sections, you will find areas where there's granulosa cell neoplasia in these self-destructing granulosa cell tumors. They're not cystic ovarian disease. Also in the horse, you will find dermoid formation. These are large neoplasms of the ovary that contain hair and keratin debris. They may rarely be true teratomas if they have structures derived from all three germ cell layers. This is a dermoid, large ovarian neoplasm of young mares. Hematomas of the ovary. All ovarian hematomas I have ever seen have been lined by luteal tissue. They've all been seen in animals that have had colic and endotoxemias, and they, like I said, since they're all lined by luteal tissue, I believe they represent a form of a luteal cyst, an anovulatory follicle that, because of endotoxemia, since I see them always associated with histories of colic and endotoxemia, I believe they represent a hemorrhagic luteal cyst. With time, this luteal lining that is seen right along here, and of course a well-organized connective tissue capsule around it, this one I knew the history of. It had a peritonitis for 3 months, and it had, because of a surgical sponge that was left in the abdomen, and you have a hemorrhagic luteal cyst in this mare. They will rupture and bleed out. They also resemble, only they're larger than, they resemble the so-called transitional follicles of mares that you see, another anovulatory structure that will regress by itself in the mare in the non-breeding season. Inclusion cysts in the hilus of the ovary of the mare, they will form, these are like the subepithelial inclusion cysts seen in dogs, old bitches. They ovulate in the ovulation fossa, so these tend to form in the ovulation fossa. They are lined by a specialized germinal epithelium of the mesothelium over the ovary, and they capture them. They will secrete, form larger cysts as animals cycle, and inclusion cysts in the hilus of the ovary. Again, typical of the horse. Stallions get neoplasms of the testicle. Here we have a seminoma, grayish testicle tumor, often associated with hemorrhage, just like in dogs. Here we have an interstitial cell tumor of the testicle of a horse, and much more yellow, typical of the interstitial cell tumor. Hydrocele, you can see it in the horse as well. In this case, it was due to necrosis of the testicle from torsion. Here is the cystic wall of that tor's testicle, fibrous interface between that and degenerating testicular tissue. The contralateral testicle is undergoing degeneration as well. Testicular torsion and hydrocele. In horses, stallions, in salmonellosis, it becomes septic and undergo endotoxemia. You'll have knee infarcts. Infarcts of the testicles are very, very common in stallions with salmonellosis. Seminal vesiculitis, you must be careful about overdiagnosing that. Here's a seminal vesicle, a normal one. When you open them up, they have a clear secretion, but because of shedding of epithelial cells, it will get it'll appear turbid. Be sure you do an impression smear of that, and all you'll see are epithelial lining cells. As opposed to this seminal vesicle that's infected, a thick wall, and you've got an exudate in the center of it. They will form little concretions as well, just like in the case of cystic prostatitis, you'll form concretions in it. But this is seminal vesiculitis in a horse. This is just a normal one with a shedding of cells into this normal secretion of the seminal vesicle as a post-mortem change. Squamous cell carcinoma, you can't not talk about that in the stallion. Apigmented areas, reflected sunlight on the ventrum, and a very, very necrotizing process on the surface because it's lost its integrity, and squamous cell carcinoma has a lot of different forms. Prepuse prolapse, penile prolapse due to ace-promazine injection. They still give ace-promazine to horses, and they still will get prolapse of the penis, and this horse was ultimately put down. Penile prolapse has also been described in debilitated old stallions as well. the cleft palate in the horse, just like in every other species. Segmental aplasia of the GI tract in the horse. Here we have the small intestine as it led into the cecum, and here's where it didn't join up, and you have distension of the proximal GI tract, and the colon is minuscule. Segmental aplasia. Adontia of the jaws of this horse. Here we have a congenital adontia, and if you compare that to a normal one, it's obvious. Here we should have this is an age-matched horse. The incisors are present, the molars are present. Here, very, very small incisors, one set of molars, small incisors, no molars, molars here in a normal. So congenital adontia, just a congenital abscess. Common tooth disease in the horse occurs in aged horses or mature horses through alveolitis. And it can occur, the onset depends on what their diets are. If they wear down the table of the teeth quickly, they will get a patent infundibula. And these pins are stuck right through the infundibula, through the bottom of the tooth, because you couldn't do this if there was enamel. These needles that you see here and here would break right off. But because of excessive wear of the table, there's been opening up of the infundibulum, and the animal had an alveolitis and the tooth was extracted. Patent infundibulum, the most common cause of tooth disease in horses. When they lose teeth, of course, they will get the typical step mouth, and the tooth on the opposite side doesn't wear evenly, and it will grow down into the jaw on the opposite side. So you have severe dental wear lesion here, gingival hyperplasia, and step mouth. And also as they get older, because the teeth open up and the incisors are more anteriorly inclined, you'll have more pressure on these teeth to actually grow up into defects where teeth have grown out on the opposite side. So step mouth is even more prominent when you've got this parrot mouth. Cystic dentigerous cyst, what they look like, they're full of fluid, mucin, a dentigerous cyst in a young horse. The esophagus in the horse normally is stratified squamous epithelial